Gastrointestinal Audiobook for USMLE Step 1. The first subtopic is gastrointestinal embryology. Now let's talk about the development of the tongue, taste, and the pharyngeal arches involved. The first pharyngeal arch forms the anterior two-thirds of the tongue, and sensation here is carried via cranial nerve 5 branch 3, while taste is conveyed by cranial nerve 7. Then, the third and fourth pharyngeal arches come into play, forming the posterior one-third of the tongue, where both sensation and taste are mainly carried through cranial nerve 9, but the extreme posterior part is handled by cranial nerve 10. Are you following me? Motor innervation, on the other hand, is controlled mostly by cranial nerve 12, which innervates the hyoglossus, responsible for retracting and depressing the tongue, the genioglossus, which protrudes the tongue, and the styloglossus, which draws the sides of the tongue upward to form a trough needed for swallowing. However, motor innervation to the palatoglossus is an exception. It comes from cranial nerve 10, and this muscle functions to elevate the posterior tongue during swallowing. So remember the mnemonic, the genie comes out of the lamp in style, and cranial nerve 10 innervates the palatoglossus. When it comes to taste, the cranial nerves involved include cranial nerve 7, 9, and cranial nerve 10, and all of them relay taste to the nucleus tractus solitarius, also known as the NTS. For pain, the cranial nerves responsible are cranial nerve 5 branch 3, cranial nerve 9, and cranial nerve 10, and for motor functions, it's primarily cranial nerve 10 and cranial nerve 12. This entire system works in perfect harmony to control the tongue's movement, sensation, and taste. When we see the normal gastrointestinal embryology, starting with the foregut, it extends from the esophagus all the way to the duodenum, at the level of the pancreatic duct and common bile duct insertion, which is known as the ampulla of Fata. Between the 4th and 6th weeks of development, the stomach rotates 90 degrees in a clockwise direction. Are you following me? This rotation causes the left vagus nerve to become anteriorly positioned, while the right vagus nerve shifts to a posterior position. You should remember this, because it sets the stage for how the nerves innervate the abdominal organs. Now let's talk about the midgut. It spans from the lower duodenum to the proximal two-thirds of the transverse colon. Around the 6th week of development, the midgut undergoes physiologic herniation through the umbilical ring, and at this stage, the yolk sac remains connected to the midgut through the vitelline duct, also called the omphallomesenteric duct. Then comes the 10th week, when the midgut returns into the abdominal cavity, and during this return, it rotates around the superior mesenteric artery, first about 90 degrees before the 10th week, and then the remaining 180 degrees happens during the 10th week, as the intestinal contents retract back into the abdominal cavity, completing a total 270-degree counterclockwise rotation. Now listen carefully, the hindgut picks up where the midgut ends, beginning at the distal one-third of the transverse colon and extending down to the anal canal, just above the pectinate line. These three gut regions, foregut, midgut, and hindgut, have distinct vascular supplies, and you should remember this clearly. The foregut is supplied by the celiac trunk, the midgut by the superior mesenteric artery, and the hindgut by the inferior mesenteric artery, all of which branch off from the aorta. Now let's talk about ventral wall defects, which are developmental abnormalities caused by the failure of specific embryologic fold closures. Failure of the rostral fold closure leads to sternal defects, such as ectopia cordis. When the lateral folds fail to close, conditions like omphaloceal and gastroschisis occur. And failure of the caudal fold closure results in bladder exstrophy. You should remember this classification clearly, as it helps in understanding the origin of each defect. Now listen carefully, let's compare gastroschisis and omphaloceal. In gastroschisis, there is paraumbilical herniation of abdominal contents through an abdominal wall defect. These contents are not covered by peritoneum or amnion, and the defect is often right-sided or paraumbilical. On the other hand, in omphaloceal, abdominal contents herniate through the umbilical ring, and they are covered by both peritoneum and amnion, which gives it a midline, membrane-covered appearance with a light gray, shiny sac. Are you following me? Gastroschisis is not commonly associated with chromosomal abnormalities and generally has a good prognosis, but omphalocele is associated with congenital anomalies, including trisomies 13 and 18, Beckwith-Weidman syndrome, and other structural abnormalities such as cardiac, genitourinary, and neural tube defects. Now let's shift to congenital umbilical hernia. This occurs when there is a delay in the spontaneous closure of the umbilical ring after the physiological herniation of the midgut. It results in a patent umbilical orifice, which is covered by skin, and often forms a bulge that is reducible, but it tends to protrude with increased intra-abdominal pressure, such as when a baby cries. This condition may be associated with congenital disorders, including Down syndrome and congenital hypothyroidism. You should remember that small defects often close on their own, without the need for intervention. Are you ready? Let's talk about tracheoesophageal anomalies, beginning with esophageal atresia, EA, accompanied by distal tracheoesophageal fistula, TEF, which is the most common form, making up about 85% of cases. It typically presents in utero as polyhydramnios, due to the fetus being unable to swallow amniotic fluid. After birth, neonates drool, choke, and vomit with the first feeding. The TEF allows air to enter the stomach, and this can be seen on a chest X-ray as a prominent gastric bubble. Cyanosis can occur due to laryngospasm, as a reflex to avoid reflux-related aspiration. A key clinical test is the failure to pass a nasogastric tube into the stomach. These anomalies are often associated with fodder or vactral defects. In the H-type variant, the fistula resembles the shape of the letter H. In pure EA, the chest X-ray shows a gasless abdomen. Now listen carefully as we move to hypertrophic pyloric stenosis, which is the most common cause of gastric outlet obstruction in infants. It typically presents with a palpable olive-shaped mass in the epigastric region, caused by hypertrophy and hyperplasia of the pyloric sphincter muscle. You may also observe visible peristaltic waves and postprandial, non-bilious, projectile vomiting around 2 to 6 weeks of age. It's more common in firstborn males and has been associated with exposure to macrolides. This condition results in hypokalemic, hypochloremic metabolic alkalosis, due to vomiting of gastric acid and subsequent volume contraction. Diagnosis is confirmed via ultrasound, which shows a thickened and lengthened pylorus, and the treatment is surgical incision of the pyloric muscle, also called pyloromyotomy. Now let's wrap up with intestinal atresia. This condition presents with bilious vomiting and abdominal distension within the first 1 to 2 days of life. In duodenal atresia, the lumen fails to recanalize from its solid cord stage. On X-ray, this presents as the classic double bubble sign, showing a dilated stomach and proximal duodenum. It is associated with Down syndrome. In jejunal and ileal atresia, the cause is a disruption of mesenteric vessels, usually the superior mesenteric artery, which leads to ischemic necrosis and segmental resorption of fetal intestine. This results in the bowel becoming discontinuous, and the X-ray may show a triple bubble sign, with a dilated stomach, duodenum, and proximal jejunum, and a gasless colon. This type is associated with cystic fibrosis and gastroschisis, and risk factors include maternal tobacco smoking and use of vasoconstrictive drugs, such as cocaine, during pregnancy. Now, let's shift our focus to the embryological origins of the pancreas and spleen. The pancreas, which is derived from the foregut, forms from both ventral and dorsal buds. The ventral pancreatic bud contributes to the uncinate process, while both buds contribute to the pancreatic head and the main pancreatic duct. In annular pancreas, there is abnormal rotation of the ventral pancreatic bud, forming a ring of tissue encircling the second part of the duodenum. This may lead to duodenal narrowing and vomiting, and is associated with Down syndrome. Another condition, pancreas divisum, occurs when the ventral and dorsal parts fail to fuse by the 7th week of development. This common anomaly is often asymptomatic but can cause chronic abdominal pain or pancreatitis. Moving on to the spleen, it arises in the mesentery of the stomach, specifically the dorsal mesogastrium, making it mesodermal in origin. However, despite its mesodermal lineage, it has a foregut blood supply. This supply comes from the celiac trunk via the splenic artery, making it a structurally and functionally unique organ. Unlike the pancreas, the spleen does not arise from the gut tube itself, but its relationship with the stomach and mesenteries is embryologically significant. This duality of mesodermal origin with a foregut supply is a key feature. Remember this for understanding splenic pathology and surgical implications. Are you following me so far? Now that we've discussed embryologic structures, it's time to examine retroperitoneal anatomy. Retroperitoneal structures lie posterior to, and outside of, the peritoneal cavity. Trauma to these areas can lead to blood or gas accumulation in the retroperitoneal space, which can be clinically subtle but serious. The mnemonic, SAD pucker, helps recall them: suprarenal glands, aorta and IVC, duodenum, second to fourth parts, pancreas, except tail, ureters, colon, descending and ascending, kidneys, esophagus, thoracic part, and rectum, partially. Take a mental note of this, doctors. These structures often have distinct patterns of injury and imaging findings. Switching gears, let's dive into important gastrointestinal ligaments and their clinical significance. The falciform ligament connects the liver to the anterior abdominal wall and contains the ligamentum teres hepatis, which is a derivative of the fetal umbilical vein. It may also contain patent paraumbilical veins. This ligament is a derivative of the ventral mesentery, and although not commonly manipulated, it can be important in procedures involving the anterior liver surface. Let me emphasize this: knowing what these ligaments carry can prevent surgical complications. Now listen carefully, because the next set of ligaments have major vascular implications in hepatic surgery. Building on this, let's explore the hepatoduodenal ligament, which connects the liver to the duodenum. It contains the portal triad, the proper hepatic artery, portal vein, and common bile duct. This ligament is also a derivative of the ventral mesentery and plays a vital role in controlling hepatic bleeding via the Pringle maneuver. During this maneuver, the ligament is compressed in the omental foramen to distinguish between portal inflow and hepatic outflow bleeding. It also forms the anterior border of the omental foramen, which links the greater and lesser sacs. In summary, the hepatoduodenal ligament is both a surgical and anatomical landmark. Now that we've dissected that, let's analyze the hepatogastric and gastrocolic ligaments. The hepatogastric ligament links the liver to the lesser curvature of the stomach and contains gastric vessels. It's also from the ventral mesentery and is part of the lesser omentum. Surgeons may cut this ligament to access the lesser sac during procedures. On the other hand, the gastrocolic ligament connects the greater curvature of the stomach to the transverse colon and carries gastroepiploic arteries. It arises from the dorsal mesentery and is part of the greater omentum. These attachments determine their anatomical and clinical relevance during abdominal surgeries. Let's pivot to the remaining key ligaments, namely the gastrosplenic and sphenorenal ligaments. The gastrosplenic ligament connects the greater curvature of the stomach to the spleen and contains the short gastric and left gastroepiploic vessels. It's derived from the dorsal mesentery and separates the greater and lesser sacs on the left. The sphenorenal ligament, meanwhile, attaches the spleen to the left pararenal space and contains the splenic artery and vein, along with the tail of the pancreas. Both are part of the greater omentum. To recap what we've just covered, these ligaments are crucial in both surgical access and maintaining organ positioning. Now, let's shift our focus to the anatomy of the digestive tract wall. Starting from the inside and moving outward, we have the mucosa, which includes the epithelium, lamina propria, and muscularis mucosa, the submucosa, which houses the submucosal nerve plexus or Meissner plexus and secretes fluid while also containing blood vessels, then the muscularis externa, which includes the myenteric or Auerbach plexus and controls motility, and finally the outermost layer, either serosa when intraperitoneal or adventitia when retroperitoneal. Ulcers can extend into the submucosa and the inner or outer muscular layers. Erosions, however, are confined to the mucosa only. Frequency of slow waves, generated by interstitial cells of Cajal, follows this order: duodenum more than ileum more than stomach. With that covered, let's transition to digestive tract histology and tissue specialization. In the esophagus, the lining is non-keratinized stratified squamous epithelium. The upper one-third consists of striated muscle, while the middle and lower two-thirds consist of smooth muscle, with some overlap at the transition. In the stomach, the lining contains gastric glands, where parietal cells appear eosinophilic or pink, and chief cells are basophilic. The duodenum features villi and microvilli to increase the absorptive surface, along with Brunner glands and the submucosa, which secrete bicarbonate. It also contains crypts of Lieberkühn, which contain stem cells that replace enterocytes and goblet cells and Paneth cells that secrete defensins, lysozyme, and TNF. There is also plicae-circulars in the distal duodenum. Switching gears, let's dive into the jejunum, ileum, and colon. The jejunum has villi, crypts of Lieberkühn, and tall, prominent, and numerous plicae-circulars, giving it a feathered appearance and increased surface area. The ileum also has villi, crypts of Lieberkühn, and proximal plicae-circulars, plus pyre patches which are lymphoid aggregates in the lamina propria and submucosa. It contains the largest number of goblet cells in the small intestine. The colon, meanwhile, has crypts of Lieberkühn packed with goblet cells but lacks villi altogether. It's time to explore the abdominal aorta and its branches. The abdominal aorta gives rise to the superior mesenteric artery and inferior mesenteric artery, while the hypogastric artery refers to the internal iliac artery. Arteries supplying GI structures are single and branch anteriorly. Arteries supplying non-GI structures are paired and branch laterally and posteriorly. 2. Watershed areas, in the colon are prone to ischemia in states like hypotension or embolism. These are the splenic flexure, supplied by the superior mesenteric artery and inferior mesenteric artery branches, and the rectosigmoid junction, where IMA branches and the superior rectal artery overlap. Stay with me, because this vascular layout underpins ischemic colitis. Let's pivot to two clinical syndromes involving the SMA and surrounding anatomy. Nutcracker syndrome is caused by compression of the left renal vein between the SMA and the aorta. This can lead to abdominal or flank pain, gross hematuria from rupture of renal varicosities, and left-sided varicocele. Superior mesenteric artery syndrome, on the other hand, is characterized by intermittent intestinal obstruction symptoms, especially postprandial pain. It results from SMA and aorta compressing the transverse or third portion of the duodenum. This typically occurs in people with diminished mesenteric fat, including those with rapid weight loss, low body weight, malnutrition, or after gastric bypass surgeries. Now let's talk about the gastrointestinal blood supply and innervation, and how it relates to the embryonic development of the gut. The foregut is supplied by the celiac artery, with parasympathetic innervation from the vagus nerve, and this region corresponds to the T12 to L1 vertebral level. It includes the pharynx, though only supplied by the vagus nerve, and extends to the lower esophagus, which receives only celiac artery branches, continuing on to the proximal duodenum, and also includes the liver, the gallbladder, the pancreas, and the spleen, which is derived from mesoderm. Are you following me? Moving on to the midgut, this region is supplied by the superior mesenteric artery, or SMA, and still receives parasympathetic innervation from the vagus nerve, with its vertebral level located around L1. The midgut begins from the distal part of the duodenum, continues through the jejunum, the ileum, the cecum, and extends up to the proximal two-thirds of the transverse colon, making it a large and active part of the gastrointestinal tract. Now let's continue with the hindgut, which is supplied by the inferior mesenteric artery, or IMA, and unlike the other two regions, it receives parasympathetic innervation from the pelvic splanchnic nerves, and this part corresponds to the L3 vertebral level. The hindgut begins at the distal one-third of the transverse colon, passes through the descending colon, the sigmoid colon, and extends down to the upper portion of the anal canal, marking the end of the gut supplied by branches of the abdominal aorta. Now listen carefully, because sympathetic innervation in the gastrointestinal system doesn't follow the same pathway as the parasympathetic. It arises from the abdominal prevertebral ganglia, and these include the celiac ganglion, the superior mesenteric ganglion, and the inferior mesenteric ganglion, which correspond respectively to the foregut, midgut, and hindgut. These ganglia are important relay points for sympathetic fibers that travel to their target organs, where they modulate blood flow, motility, and secretory functions. Are you ready to understand the branches of the celiac trunk? It divides into three major arteries, the common hepatic artery, the splenic artery, and the left gastric artery, and together, they form the main blood supply to the foregut. These arteries deliver oxygenated blood to vital organs like the stomach, liver, pancreas, and spleen, and also serve as major anatomical landmarks during surgical procedures involving the upper abdomen. You should remember this: strong anastomosis exists between the left and right gastroepiploic arteries, and also between the left and right gastric arteries, ensuring collateral blood flow to the stomach. Additional important branches include the cystic artery, which supplies the gallbladder, the esophageal branches, the short gastric arteries, and the left gastroepiploic artery, all of which usually originate from the splenic artery and contribute to the rich vascular network in the upper abdomen. Now let's go over more branches. These include the right gastric artery, the gastroduodenal artery, the posterior superior pancreaticoduodenal artery, and the anterior superior pancreaticoduodenal artery, all of which play key roles in supplying the stomach, duodenum, and pancreas. From the common hepatic artery, we also get the left hepatic artery, the right hepatic artery, and finally the proper hepatic artery, which continues into the liver, ensuring a direct and reliable blood supply to hepatic tissues. Finally, let's summarize what is supplied by each major artery. The left gastric artery mainly supplies the lesser curvature of the stomach and part of the esophagus, while the common hepatic artery branches to supply the liver, the gallbladder, and parts of the stomach and duodenum. The splenic artery supplies the spleen, the pancreas, and also gives off short gastric and left gastroepiploic branches that nourish the fundus and greater curvature of the stomach. These anastomoses create redundancy in the blood supply, which is crucial for protecting the gut against ischemia. Now let's talk about portosystemic anastomoses, which are crucial in understanding complications of portal hypertension. Normally, blood from the gastrointestinal tract drains into the portal venous system, which carries it to the liver for filtration before it enters the systemic venous system. But when portal pressure rises, blood is forced to find alternate routes, flowing backward into systemic veins, and causing visible signs in different parts of the body. These detours between the portal and systemic circulations are known as portosystemic shunts, and they allow blood to bypass the liver entirely, disrupting normal detoxification. Now listen carefully, because under pathologic conditions like portal hypertension, blood can back up from the portal vein into several smaller veins. This abnormal flow causes distension and swelling of anastomotic veins, which are usually quiet during normal physiology. Among the major drainage pathways involved are the left gastric vein, the splenic vein, the superior mesenteric vein, and the inferior mesenteric vein, all of which contribute to the portal system. Meanwhile, the hepatic vein, the IVC, and the azygous vein belong to the systemic venous system, and they receive diverted blood through the anastomotic sites. Now let's talk about the clinical signs and sites where these anastomoses become visible. At the esophagus, esophageal varices form due to a connection between the left gastric vein and the esophageal veins that drain into the azygous system. At the umbilicus, caput medusae appears when blood flows from the paraumbilical vein to small epigastric veins, which are branches of the inferior and superficial epigastric veins of the anterior abdominal wall. At the rectum, anorectal varices form when the superior rectal vein from the portal system anastomoses with the middle and inferior rectal veins, part of the systemic system. You should remember this: varices of the gut, the butt, and caput, also called caput medusae, are the classic signs of advanced portal hypertension. These varices are not just cosmetic issues but dangerous sites of potential hemorrhage, especially in the esophagus, where bleeding can be fatal. These signs reflect the body's attempt to bypass a high-pressure portal system, but they come at a significant clinical cost. That's why detecting and managing these varices is a key goal in treating patients with chronic liver disease and portal obstruction. Now let's dive into one of the treatments, called transjugular intrahepatic portosystemic shunt, or TIPS. This procedure creates a direct anastomosis between the portal vein and the hepatic vein, allowing blood to flow into the systemic circulation and bypass the liver, thereby relieving portal pressure. By shunting blood away from the high-resistance hepatic sinusoids, TIPS helps reduce the size of varices and lowers the risk of bleeding. It is commonly used in patients with cirrhosis and recurrent variceal bleeding, offering significant relief when other measures fail. But now listen carefully, because while TIPS helps control portal hypertension, it can also precipitate hepatic encephalopathy, a serious complication. This happens because the blood bypasses the liver's filtering mechanisms, so ammonia and other nitrogenous wastes are no longer adequately cleared. As a result, these toxins accumulate in the systemic circulation, affecting the brain and leading to confusion, altered consciousness, or even coma. That's why the use of TIPS must always balance the benefit of reducing portal pressure against the risk of systemic toxin buildup. Now let's talk about the pectinate line, which is also called the dentate line, and is formed where the endoderm, from the hindgut, meets the ectoderm. At this anatomical boundary, we observe two distinct types of hemorrhoids. Internal hemorrhoids, which occur above pectinate line, are caused by abnormal distension of the anal venous plexus, and their risk factors include older age and chronic constipation. These hemorrhoids receive visceral innervation, and are not painful. In contrast, external hemorrhoids receive somatic innervation from the inferior rectal branch of the pudendal nerve, and are painful if thrombosed. Are you following me? An anal fissure is a tear in the anoderm that lies below the pectinate line, and it causes pain while pooping, and usually presents with blood on toilet paper. Anal fissures are commonly located in the posterior midline, and this is because the area is poorly perfused. These fissures are also associated with low-fiber diets, and with constipation, which increases strain and leads to tearing. Understanding their location, cause, and innervation is critical in managing anorectal pain properly, especially in outpatient settings. Now listen carefully to the innervation, arterial supply, venous drainage, and lymphatics above and below the pectinate line. Visceral innervation comes from the inferior hypogastric plexus, spanning T12 to L3. The arteries above the line include the superior rectal artery, a branch of the inferior mesenteric artery, or IMA. The veins above the pectinate line include the superior rectal vein, which drains into the inferior mesenteric vein, then to the splenic vein, and finally to the portal vein. The lymphatics drain into the internal iliac lymph nodes. Let's shift now to the structures below the pectinate line. Somatic innervation is provided by the pudendal nerve, specifically from segments S2 to S4. The arterial supply comes from the inferior rectal artery, which is a branch of the internal pudendal artery. The venous drainage includes the inferior rectal vein, which flows into the internal pudendal vein, then into the internal iliac vein, followed by the common iliac vein, and finally into the IVC. The lymphatic drainage below the line flows to the superficial inguinal lymph nodes, which are palpable on physical exam. Now let's revisit some related pathology. Below pectinate line, some pathologies include external hemorrhoids, anal fissures, and squamous cell carcinoma. Because external hemorrhoids and anal fissures are located below the pectinate line, they are both painful due to somatic innervation. Also, squamous cell carcinoma may develop in the epithelium below the line, which is derived from ectoderm. Above pectinate line there is internal hemorrhoid and adenocarcinoma. Now let's turn to the liver tissue architecture, and understand the functional unit of the liver, which is made up of hexagonally arranged lobules that surround a central vein, with portal triads at the edges. These triads consist of a portal vein, a hepatic artery, bile ducts, and lymphatics. The apical surface of hepatocytes faces the bile canaliculi, while the basolateral surface faces the sinusoids. Kupffer cells, which are specialized macrophages, are located in the sinusoids, and they clear bacteria and damaged or senescent red blood cells. Are you ready to learn about more cells? Hepatic stellate cells, also called Ito cells, are located in the space of Dees, and when quiescent, they store vitamin A. When activated, they produce extracellular matrix, and are responsible for hepatic fibrosis. The liver receives a dual blood supply, about 80% from the portal vein, and 20% from the hepatic artery. This dual supply supports its metabolic and detoxifying functions, even under varying hemodynamic conditions, which is essential during shock, hypoxia, or liver injury. Now listen carefully, the liver is divided into 3 zones with distinct functions and vulnerabilities. Zone 1, the periportal zone, is affected first by viral hepatitis, is the best oxygenated, and is most resistant to circulatory compromise. It is also where ingested toxins, such as cocaine, exert their effects. Zone 2, the intermediate zone, is less studied but is known to be involved in diseases like yellow fever. Each zone has a unique role in hepatic metabolism, inflammation, and regeneration, making zonal pathology crucial in liver disease. Finally, let's discuss Zone 3, which is the pericentral, or centralobular zone, and is the first affected by ischemia due to its being the least oxygenated, as seen in congestive hepatopathy. It contains a high concentration of cytochrome P450 enzymes, and is the most sensitive to metabolic toxins like ethanol, carbon tetrachloride, CCl4, rifampin, and acetaminophen. It is also the site of alcoholic hepatitis, and because of this metabolic burden and hypoxia, Zone 3 is often the zone most severely damaged in liver failure. Now, let's talk about biliary structures. Cholangiography shows filling defects in the gallbladder and common bile duct. Gallstones that reach the confluence of the common bile and pancreatic ducts at the ampulla of Fata can block both the common bile and pancreatic ducts, which is known as the double duct sign. This causes both cholangitis and pancreatitis, respectively. Tumors that arise in the head of the pancreas, usually ductal adenocarcinomas, can cause obstruction of the common bile duct, leading to an enlarged, non-tender gallbladder with jaundice, which is referred to as Courvoisier's sign. Next, let's talk about organization of femoral region. From lateral to medial, the nerve artery vein lymphatics are aligned. You move from lateral to medial to find your navel. In the femoral triangle, you'll find the femoral nerve, artery, and vein, with the venous structures near the penis. The femoral sheath is a facial tube located 3 to 4 centimeters below the inguinal ligament. This sheath contains the femoral vein, artery, and canal, which holds the deep inguinal lymph nodes, but not the femoral nerve. Now listen carefully, the anterolateral abdominal wall consists of multiple layers, when we see starting from deep and moving toward the surface. First, we have the parietal peritoneum, followed by the extraperitoneal tissue, and next comes the transversalis fascia. Then, we encounter the transversus abdominis muscle, which lies just beneath the internal oblique muscle. Over this is the aponeurosis of the external oblique muscle, forming a tough fibrous sheet. These layers play a crucial role in structural support and help define the inguinal canal. Understanding them is key when discussing herniation and related anatomy. Are you ready to explore some important landmarks and weak points? The deep, also called internal, inguinal ring is where indirect hernias usually protrude. The superficial, or external, inguinal ring lies more laterally and allows passage into the scrotum. The inferior epigastric vessels are essential because they define the separation between direct and indirect hernias. Direct hernias appear medial to these vessels, while indirect ones appear lateral. These distinctions help in clinical identification and treatment planning. A clear understanding of these locations aids surgical precision. Now let's talk about the medial structures from the inguinal canal, which are important landmarks during surgery. First, the medial umbilical ligament stands out, followed by the median umbilical ligament running along the midline. The rectus abdominis muscle adds muscular support, while the small pyramidalis muscle lies anteriorly. The conjoint tendon represents the fusion of the internal oblique and transversus abdominis tendons. At the very center, you'll find the linea alba, a fibrous midline structure. All these help support the abdominal wall and serve as reference points for hernia repairs. Are you following me? Good, now let's talk about the spermatic cord, which contains several layers from outer to inner. First comes the external spermatic fascia, which arises from the external oblique muscle. Next is the cremasteric muscle and its fascia, derived from the internal oblique. Finally, we have the internal spermatic fascia, which originates from the transversalis fascia. These layers encase the cord structures and are vital in testicular support. They also help determine how hernias interact with surrounding tissues. Their origins explain their role in indirect hernias especially. Now listen carefully, the myopectineal orifice is a region of anatomical vulnerability. It includes an invagination of the transversalis fascia and the internal inguinal ring. This area is particularly significant because it encompasses all major hernia sites. Hesselbach's triangle, a key part of this orifice, is bordered inferiorly by the pubic tubercle and pubic symphysis. Laterally, it is marked by the inferior epigastric vessels, and medially by the lateral edge of the rectus abdominis. Hernias often exploit this region due to structural weakness. Proper knowledge of these borders helps avoid surgical complications. Are you ready to explore what passes through the inguinal canal? In males, it contains the ductus deferens, internal spermatic vessels, and the ilioinguinal nerve. In females, the round ligament of the uterus replaces the ductus deferens. Hernias are essentially protrusions of peritoneum through weak openings. The hernia content may be at risk of incarceration, meaning they can't be pushed back in, or strangulation, which causes ischemia and tissue death. Complicated hernias often present with signs like tenderness, redness, or fever. Now listen carefully, the Spigelian hernia, also called spontaneous lateral ventral hernia or hernia of semilunar line, occurs through defects between the rectus abdominis and the semilunar line in the Spigelian aponeurosis. Most occur in the lower abdomen due to lack of the posterior rectus sheath. Presentation is variable but may include abdominal pain and a palpable lump along the Spigelian fascia. Diagnosis is made using ultrasound and CT scan. This type of hernia requires high suspicion for identification. Its anatomical location is along the lateral border of the rectus muscle. Imaging is key for confirming its presence. Now let's talk about diaphragmatic hernia, where abdominal structures enter the thorax, and bowel sounds may be heard on chest auscultation. The most common causes differ by age. In infants, it's a congenital defect of the pleuroperitoneal membrane, leading to left-sided herniation, while the right hemidiaphragm is relatively protected by the liver. In adults, the cause is laxity or defect of the phrenoesophageal membrane, resulting in hiatal hernia. That's when part of the stomach herniates through the esophageal hiatus. Are you ready to differentiate types of hiatal hernias? In a sliding hiatal hernia, the gastroesophageal junction is displaced upward as the gastric cardia slides into the hiatus, creating an hourglass stomach. It is the most common type and is associated with GERD. In contrast, a paraesophageal hiatal hernia keeps the gastroesophageal junction usually normal, but the gastric fundus protrudes into the thorax. Now listen carefully, an indirect inguinal hernia protrudes through the internal, or deep, inguinal ring, the external, or superficial, inguinal ring, and extends into the groin. It enters the internal inguinal ring lateral to the inferior epigastric vessels. It is caused by failure of the processus vaginalis to close, which can also form a hydrocele. This hernia may be noticed in infants or discovered in adulthood. It is much more common in males and follows the pathway of testicular descent. It is covered by all three layers of the spermatic fascia. Now let's discuss the direct inguinal hernia, which protrudes through the inguinal, or Hesselbach, triangle. It bulges directly through the parietal peritoneum, medial to the inferior epigastric vessels, but lateral to the rectus abdominis. It goes through the external, or superficial, inguinal ring only, and is covered by the external spermatic fascia. This hernia usually occurs in older males due to acquired weakness of the transversalis fascia. And here's a helpful mnemonic: MD don't lie, medial to the inferior epigastric vessels is a direct hernia, while lateral means indirect hernia. Now let's talk about the femoral hernia, which protrudes below the inguinal ligament, passing through the femoral canal, and sits below and lateral to the pubic tubercle. It is more common in females, though inguinal hernias remain the most common overall. Femoral hernias are more likely to present with incarceration or strangulation, as compared to inguinal hernias. Gastrointestinal physiology is our next fucking topic. Let's talk about gastrointestinal regulatory substances. Gastrin is secreted by G cells in the antrum of the stomach and the duodenum. It increases gastric H+ secretion, promotes growth of the gastric mucosa, and enhances gastric motility. It is stimulated by stomach distension, alkalinization, amino acids, peptides, and vagal stimulation via gastrin-releasing peptide, or GRP. It is inhibited by pH less than 1.5. Gastrin levels increase with chronic PPI use, and also in chronic atrophic gastritis such as in H. pylori infection, and they rise markedly in Zollinger-Ellison syndrome, or gastrinoma. Listen carefully, ghrelin is secreted from the stomach and it increases appetite, remember it as the ghrelin stomach. Its secretion rises in the fasting state and decreases after food intake. Ghrelin levels are increased in Prader-Willi syndrome, while they are reduced after gastric bypass surgery. Now let's talk about somatostatin, which is secreted by D cells located in the pancreatic islets and GI mucosa. It decreases gastric acid and pepsinogen secretion, reduces pancreatic and small intestine fluid secretion, and inhibits gallbladder contraction. It also suppresses insulin and glucagon release. It is stimulated by acid and inhibited by vagal stimulation. Somatostatin inhibits secretion of many hormones, promoting what is called somatostasis. Octreotide, a somatostatin analog, is used to treat conditions like acromegaly, carcinoid syndrome, VIPoma, and variceal bleeding. Are you following me? Cholecystokinin is released by I cells in the duodenum and jejunum. It increases pancreatic secretion, stimulates gallbladder contraction, slows gastric emptying, and relaxes the sphincter of Oddi. Its release is triggered by fatty acids and amino acids in the intestinal lumen. Cholecystokinin acts through neural muscarinic pathways to promote pancreatic enzyme secretion. Secretin is secreted by S cells of the duodenum. It increases pancreatic bicarbonate secretion, reduces gastric acid secretion, and enhances bile secretion. Secretin release is stimulated by acid and fatty acids in the duodenal lumen. Bicarbonate neutralizes gastric acid in the duodenum, which allows pancreatic enzymes to function properly. You should remember this, glucose-dependent insulinotropic peptide is secreted by K cells of the duodenum and jejunum. It has both exocrine and endocrine actions. As exocrine it decreases gastric H+ secretion and as endocrine it increases insulin release. It is stimulated by fatty acids, amino acids, and oral glucose. This hormone is also called gastric inhibitory peptide, or GIP. Oral glucose loads increase insulin more than intravenous glucose due to GIP secretion. Now let's talk about motilin, which is secreted by the small intestine and is responsible for producing migrating motor complexes, or MMCs. Its secretion increases during the fasting state. Motilin receptor agonists, like erythromycin, are used to stimulate intestinal peristalsis. Are you ready for the next one? Vasoactive intestinal polypeptide, or VIP, is secreted by parasympathetic ganglia in sphincters, the gallbladder, and the small intestine. It increases intestinal water and electrolyte secretion, promotes relaxation of intestinal smooth muscle and sphincters, and decreases gastric acid secretion. VIP is stimulated by distension and vagal stimulation, and inhibited by adrenergic input. A VIPoma is a non-alpha, non-beta islet cell pancreatic tumor that secretes VIP. It is associated with watery diarrhea, hypokalemia, and achlorhydria, also known as WDHA syndrome. Now listen carefully, nitric oxide increases smooth muscle relaxation, including that of the lower esophageal sphincter, or LES. Loss of nitric oxide secretion is implicated in increased lower esophageal sphincter tone seen in achalasia. Now let's move on to gastrointestinal secretory products. Gastric acid is secreted by parietal cells in the stomach. It lowers stomach pH and is stimulated by histamine, vagal stimulation via acetylcholine, and gastrin. It is inhibited by somatostatin, GIP, prostaglandin, and secretin. Autoimmune destruction of parietal cells, seen on pink or eosinophilic histology, leads to chronic gastritis and pernicious anemia. Acid secretion is tightly regulated. Now let's talk about intrinsic factor, also produced by parietal cells of the stomach. It is a vitamin B12, binding protein required for B12 uptake in the terminal ileum. Without intrinsic factor, B12 cannot be absorbed. Pepsin is secreted by chief cells in the stomach. It is involved in protein digestion and is stimulated by vagal stimulation via acetylcholine and local acid. Pepsinogen, the inactive form, is converted to active pepsin in the presence of H+. Now let's wrap up with bicarbonate, which is secreted by mucosal cells in the stomach, duodenum, salivary glands, and pancreas, as well as by Brunner glands in the duodenum. It neutralizes acid and is increased by pancreatic and biliary secretion stimulated by secretin. Bicarbonate is trapped in mucus that covers the gastric epithelium. Now let's talk about pancreatic secretions, which consist of isotonic fluid, and at low flow, there is high chloride, while at high flow, there is high bicarbonate. Alpha amylase plays a role in starch digestion and is secreted in its active form. Lipases function in lipid digestion. Proteases are involved in protein digestion and include trypsin, chymotrypsin, elastase, and carboxypeptidases. These proteases are secreted as proenzymes, also called zymogens. Dipeptides and tripeptides are degraded within the intestinal mucosa through an intracellular process. Trypsinogen is converted to the active enzyme trypsin. Now listen carefully, trypsin promotes activation of other proenzymes and cleaves additional trypsinogen molecules into active trypsin through a positive feedback loop. It is converted to trypsin by enterokinase, or enteropeptidase, which is a brush border enzyme found on the duodenal and jejunal mucosa. Now moving forward, let's focus on carbohydrate absorption mechanisms and transport proteins involved in this vital process. Are you ready? Glucose or galactose are absorbed via SGLT1, and fructose is absorbed via GLUT5 on the apical membrane of enterocytes. These monosaccharides enter the enterocyte, and then are transported across the basolateral membrane to the blood using GLUT2. The Na+/K+ ATPase maintains the sodium gradient, exchanging 3 sodium out and 2 potassium in. Only monosaccharides, including glucose, galactose, and fructose, are absorbed by enterocytes. Glucose and galactose use SGLT1, which is sodium dependent, while fructose relies on GLUT5 for facilitated diffusion. And all of this transported into blood by GLUT2 basolateral membrane. Now listen carefully, the D-xylose test uses a simple sugar that is passively absorbed in the proximal small intestine. Blood and urine levels are reduced with mucosal damage, but remain normal in pancreatic insufficiency. This test helps distinguish between mucosal causes of malabsorption and pancreatic causes. Now moving into another important section, let's talk about vitamin and mineral absorption, and how deficiencies may develop under pathological conditions or surgical interventions. You should remember this, vitamin and mineral deficiencies may develop in patients with small bowel disease, bowel resection, intestinal failure, also called short bowel syndrome, or bariatric surgery. For example, vitamin B12 deficiency may complicate terminal ileum resection and requires supplementation. Iron is absorbed as Fe2+ in the duodenum. Folates are absorbed in the duodenum and jejunum. Vitamin B12 is absorbed in the terminal ileum along with bile salts and requires intrinsic factor for uptake. Now let's break this down further, and remember this phrase, iron fist, bro, dumping syndrome involves hyperosmolar food, often sugary, moving too quickly from the stomach to the small intestine. This typically occurs after stomach or esophageal surgery. The result is rapid fluid shifts and symptoms like cramping or diarrhea. Now transitioning to the absorption pathway for vitamin B12, let's walk through the interaction of R protein, intrinsic factor, and digestive enzymes. Now listen carefully, B12 initially comes binding with P animal protein, and R protein is secreted in the saliva, the P protein is digested in stomach by pepsin, then free B12 binds are protein forming a B12, R complex, then pancreatic protease degrades R protein, allowing B12 to bind intrinsic factor. The B12, if complex proceeds through the small intestine. In the terminal ileum, B12 is absorbed along with bile salts, and the intrinsic factor is essential for this absorption. Let's spit some shit about Peyer's patches, which are unencapsulated lymphoid tissue located in the lamina propria and submucosa of the ileum. These patches contain specialized microfold, or M, cells that sample and present antigens to immune cells. B cells stimulated in germinal centers of Peyer patches and differentiate into IgA-secreting plasma cells. These plasma cells ultimately reside in the lamina propria. IgA receives a protective secretory component, and is transported across the epithelium, to the gut to deal with intraluminal antigen. Think of IgA as the intragut antibody. Now let's begin with bile, which is composed of bile salts. These are bile acids conjugated to glycine or taurine, making them water-soluble, along with phospholipids, cholesterol, bilirubin, water, and ions. The enzyme cholesterol 7-alpha-hydroxylase catalyzes the rate-limiting step of bile acid synthesis. The key functions of bile include digestion and absorption of lipids and fat-soluble vitamins, and excretion of bilirubin and cholesterol, which is the body's primary means of elimination. It also plays a role in antimicrobial activity through membrane disruption. Reabsorption of enteric bile salts occurs at the distal ileum. In conditions like short bowel syndrome or Crohn's disease, this reabsorption is impaired. Now listen carefully. This impaired bile salt reabsorption prevents normal fat absorption and may lead to bile acid diarrhea. Calcium, which normally binds oxalate, ends up binding fat instead. As a result, free oxalate is absorbed by the gut, increasing the frequency of calcium oxalate kidney stones. Now let's turn to bilirubin, which originates from heme metabolism. Heme is metabolized by heme oxygenase to biliverdin, which is green, and then biliverdin is reduced to bilirubin, which is yellow-brown. Unconjugated bilirubin is removed from blood by the liver, conjugated with glucuronate, and then excreted in bile. Now let's be clear about the two forms. Direct bilirubin is conjugated with glucuronic acid and is water-soluble, meaning it dissolves in water. Indirect bilirubin is unconjugated and water-insoluble. Now, gastrointestinal pathologies. First, starting from oral pathologies, we begin with aphthous ulcers, also called canker sores, which are common oral lesions. These appear as painful, shallow, round to oval ulcers covered by yellowish exudate. Recurrent aphthous stomatitis is associated with conditions such as celiac disease, IBD, SLE, Behçet syndrome, and HIV infection. Now listen closely. Squamous cell carcinoma is the most common malignancy of the oral cavity and usually affects the tongue. It is associated with tobacco use, alcohol consumption, and HPV-16 infection. Clinically, it presents as a non-healing ulcer with irregular margins and raised borders. Leukoplakia, which is a white patch, and erythroplakia, a red patch, are considered precursor lesions to this carcinoma. Next, we'll discuss sialolithiasis, which is the formation of stones in major salivary gland ducts. This includes the parotid, submandibular, or sublingual glands. Are you following me? Sialolithiasis is associated with salivary stasis, such as that seen in dehydration, and also with trauma. It typically presents as recurrent pain and swelling in the affected gland, especially before or during meals. Now moving to sialidinitis, this is inflammation of the salivary gland due to obstruction, infection such as from S. aureus or the mumps virus, or immune-mediated causes like Sjogren's syndrome. Salivary gland tumors are usually benign and most commonly affect the parotid gland. Now listen carefully. Tumors in the submandibular, sublingual, and minor salivary glands are more likely to be malignant. These tumors usually present as painless masses or swellings, but facial paralysis or pain can suggest malignant involvement. Pleomorphic adenoma, also called benign mixed tumor, is the most common salivary gland tumor. It is composed of chondromyxoid stroma and epithelium and may recur if incompletely excised or if ruptured during surgery. It also has the potential to undergo malignant transformation. Now let's continue. Warthin tumor, also called papillary cystadenoma lymphomatosum, is a benign cystic tumor with germinal centers. It may be bilateral or multifocal, and it is typically found in people who smoke. Remember the phrase, warriors from Germany love smoking. Mucoepidermoid carcinoma is the most common malignant salivary gland tumor and contains both mucinous and squamous components. Now let's move on to achalasia, a disorder involving failure of the lower esophageal sphincter to relax. Are you ready? Achalasia results from degeneration of inhibitory neurons, which contain nitric oxide and vasoactive intestinal peptide, located in the myenteric or Auerbach plexus of the esophageal wall. The condition may be primary and idiopathic or secondary to Chagas disease, which is a Trypanosoma cruzi infection, or secondary to extraesophageal malignancies through mass effect or paraneoplastic syndromes. Chagas disease can cause achalasia. Clinically, it presents with progressive dysphagia to both solids and liquids, unlike mechanical obstruction which primarily blocks solid food. Now listen carefully, achalasia is associated with increased risk of esophageal cancer. Manometry findings typically include uncoordinated or absent peristalsis, along with increased lower esophageal sphincter resting pressure. A barium swallow test will show a dilated esophagus with an area of distal stenosis, which is often described as having a bird's beak appearance. Treatment options include surgery and endoscopic procedures, such as botulinum toxin injection to relax the sphincter and improve symptoms. Now listen carefully, gastroesophageal reflux disease involves transient decreases in lower esophageal sphincter tone, and it commonly presents as heartburn, regurgitation, and dysphagia, but it may also show up as chronic cough and hoarseness, known as laryngopharyngeal reflux. This condition is associated with asthma, and the complications include erosive esophagitis, strictures, and Barrett esophagus. Now let's talk about esophagitis, which is the inflammation of the esophageal mucosa. It presents with odynophagia and dysphagia, and the types include reflux esophagitis, which is most common and secondary to GERD, and medication-induced esophagitis, secondary to drugs like bisphosphonates, tetracyclines, NSAIDs, ferrous sulfate, and potassium chloride. Eosinophilic esophagitis is chronic, immune-mediated, and eosinophil predominant, while it is associated with atopic disorders such as asthma, and you'll see esophageal rings and linear furrows on endoscopy. Infectious esophagitis is another type, and it can be caused by candida, which is most common and forms white pseudomembranes, or HSV-1, which causes punched-out ulcers, and CMV, which produces linear ulcers, all commonly seen in immunosuppressed patients. Lastly, corrosive esophagitis occurs secondary to caustic ingestion. Now let's shift the focus to Plummer-Vinson syndrome, which is characterized by a triad of dysphagia, iron deficiency anemia, and esophageal webs, and this syndrome increases the risk of esophageal squamous cell carcinoma. Just remember the phrase, Plummer dies. It may also be associated with glossitis. Moving on, Mallory-Weiss syndrome involves partial thickness longitudinal lacerations at the gastroesophageal junction, confined to the mucosa and submucosa, and it usually results from severe vomiting. It often presents with hematemesis and may or may not include abdominal or back pain, and it's usually found in patients with alcohol use disorder or bulimia nervosa. Are you following me? Let's go deeper. Esophageal varices are dilated submucosal veins in the lower one-third of the esophagus, and they occur secondary to portal hypertension. These are common in patients with cirrhosis and can be a source of life-threatening hematemesis. Now let's talk about distal esophageal spasm, which was formerly known as diffuse esophageal spasm. This involves spontaneous, non-peristaltic, and uncoordinated contractions of the esophagus, even though the lower esophageal sphincter pressure remains normal. It presents with dysphagia and angina-like chest pain, and a barium swallow might show a corkscrew appearance of the esophagus. Diagnostic confirmation comes from manometry, and treatment includes nitrates and calcium channel blockers. Let's not stop now. Scleroderma esophageal involvement features esophageal smooth muscle atrophy and fibrosis, which decreases lower esophageal sphincter pressure and leads to distal esophageal dysmotility. This results in acid reflux and dysphagia, and over time can cause strictures, Barrett esophagus, and aspiration. Remember, this is part of CREST syndrome. Are you ready for more? Esophageal perforation is most commonly iatrogenic, following esophageal instrumentation, but non-iatrogenic causes include spontaneous rupture, foreign body ingestion, trauma, and malignancy. Pneumomediastinum and subcutaneous emphysema, including signs like crepitus in the neck or chest wall, can indicate dissecting air. Borhave syndrome is a classic example. It's a transmural, usually distal esophageal rupture due to violent retching. Now listen carefully to Barrett esophagus. It involves specialized intestinal metaplasia, where non-keratinized stratified squamous epithelium is replaced with intestinal epithelium, specifically non-ciliated columnar cells with goblet cells, in the distal esophagus. This change is due to chronic GERD and is associated with increased risk of esophageal adenocarcinoma. Esophageal cancer typically presents with progressive dysphagia, starting with solids and then progressing to liquids, along with weight loss. It has an aggressive course due to the absence of a serosa in the esophageal wall, which allows for rapid local extension. Sadly, it carries a poor prognosis, because it's often diagnosed at an advanced stage. You should remember this: esophageal cancer comes in two main forms, squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma affects the upper two-thirds of the esophagus and is associated with alcohol, hot liquids, caustic strictures, smoking, achalasia, and nitrosamine-rich foods, and it is more common worldwide. On the other hand, adenocarcinoma affects the lower third of the esophagus and is linked to chronic GERD, Barrett esophagus, obesity, and tobacco smoking, and this type is more common in America. Now listen carefully. Acute gastritis involves erosions that can be caused by NSAIDs, which reduce prostaglandin E2 and in turn, decrease gastric mucosa protection, and burns, called curling ulcers, where hypovolemia causes mucosal ischemia, and brain injury, referred to as Cushing ulcer, where vagal stimulation increases acetylcholine and hydrogen ion production. It's especially common among patients with alcohol use disorder, and those who take daily NSAIDs, such as people with rheumatoid arthritis. Remember the mnemonics: burned by the curling iron, and always cushion the brain. Now let's talk about chronic gastritis, which involves mucosal inflammation, often leading to atrophy. This atrophy results in hypochlorhydria, which causes hypergastronemia, and intestinal metaplasia, increasing the risk of gastric cancers. Two main types are H. pylori, associated and autoimmune. Are you following me? H. pylori, induced chronic gastritis is the most common, and it increases the risk of peptic ulcer disease, and malt lymphoma. It typically affects the antrum first, and then spreads to the body of the stomach. Meanwhile, autoimmune chronic gastritis involves autoantibodies, T-cell induced, that target the H+/K+ ATPase on parietal cells, an intrinsic factor, raising the risk of pernicious anemia. This type primarily affects the body and fundus of the stomach. Now let's talk about Meniere disease, which is characterized by hyperplasia of the gastric mucosa. This leads to hypertrophied rugae, which appear wavy like brain gyri on imaging. Now listen carefully. Meniere disease causes excess mucus production, and with it, protein loss, and parietal cell atrophy, which leads to reduced acid production. It's a precancerous condition and presents with weight loss, anorexia, vomiting, epigastric pain, and edema, due to protein loss. You can remember this using the mnemonic WAVY: weight loss, anorexia, vomiting, epigastric pain, and edema. Now let's shift to gastric cancer, which is most commonly gastric adenocarcinoma, though it can also be lymphoma, gastrointestinal stromal tumors involving KIT or PDGFRA mutations, or rare carcinoids. It tends to spread aggressively and early, often involving lymph nodes and liver. Now are you ready? Because gastric cancer often presents late, with symptoms like weight loss, early satiety, abdominal pain, and obstruction, and sometimes signs like acanthosis nigricans or lessertralat. The intestinal type is linked to H. pylori, smoked food nitrosamines, tobacco, achlorhydria, and chronic gastritis, and usually arises on the lesser curvature, resembling ulcers with raised margins. The diffuse type is not linked to H. pylori, and is mostly due to ecadherin mutation, featuring signet ring cells which are mucin-filled cells with peripheral nuclei, and a stomach that's thickened and leathery, known as linitis plastica. Some classic metastases include Fierco node, which is involvement of left supraclavicular node by metastasis from stomach. Krukenberg tumor, which is metastasis to ovaries, typically it is bilateral, and there is abundant mucin-secreting, signet ring cells. Another one is Sister Mary Joseph nodule, which is subcutaneous periumbilical metastasis, and finally Bloomer shelf, where there is palpable mass on digital rectal exam suggesting metastasis to rectouterine pouch, pouch of Douglas. Now let's talk about peptic ulcer disease, which includes both gastric and duodenal ulcers, so listen closely to the contrasts. Gastric ulcer pain can become worse with meals, often leading to weight loss because eating aggravates the symptoms. In contrast, duodenal ulcer pain decreases with meals, which may lead to weight gain, as food provides temporary relief. When it comes to H. pylori infection, around 70% of gastric ulcers and about 90% of duodenal ulcers are associated with this organism. The underlying mechanism involves reduced mucosal protection against gastric acid in both cases, but in duodenal ulcers, there can also be increased acid secretion. Other causes include NSAID use, and in the case of duodenal ulcers, also the Zollinger-Ellison syndrome, which involves gastrin-secreting tumors. Are you following me? Because the cancer risk is quite different between these two types of ulcers. Gastric ulcers carry an increased risk of carcinoma, so it is essential to biopsy the margins to rule out malignancy and avoid missing a cancer diagnosis. On the other hand, duodenal ulcers are generally benign, and they are not routinely biopsied, which reflects their lower malignancy potential. Let's see ulcer complication begin with hemorrhage, which is the most common complication of peptic ulcers, affecting both gastric and duodenal locations, especially when the ulcer is posterior rather than anterior. A ruptured gastric ulcer on the lesser curvature of the stomach can lead to bleeding from the left gastric artery, which is a significant vascular source. Meanwhile, an ulcer located on the posterior wall of the duodenum can erode into the gastroduodenal artery, causing serious bleeding. Now listen carefully as we discuss other serious ulcer complications, starting with obstruction, which can occur at the pyloric channel or in the duodenum. Perforation is another critical emergency, and it happens more commonly in anterior duodenal ulcers than in posterior ones. When the ulcer perforates into the anterior abdominal cavity, it may release air, causing pneumoperitoneum, which can be visualized on imaging. You might see free air under the diaphragm, and patients may have referred pain to the shoulder, due to irritation of the phrenic nerve. Now let's transition to acute gastrointestinal bleeding, which can be divided into upper and lower types based on the location relative to the ligament of Treitz. Upper GI bleeding originates proximal to this ligament, and it usually presents with hematemesis or melena, often linked to peptic ulcer disease or variceal hemorrhage. Lower GI bleeding, in contrast, originates distal to the ligament of Treitz and typically presents with hematochezia, or fresh blood per rectum. Common causes of lower GI bleeding include inflammatory bowel disease, diverticulosis, angiodysplasia, hemorrhoids, anal fissures, and sometimes cancer. Now let's talk about malabsorption syndromes, which can cause diarrhea, steatorrhea, weight loss, weakness, vitamin and mineral deficiencies, and must be taken seriously. Screening is done using fecal fat, for example with the Sudan stain, which can help identify fat malabsorption. One major condition is celiac disease, also called gluten-sensitive enteropathy or celiac sprue, and it is autoimmune mediated, involving intolerance of gliadin. Gliadin is a gluten protein found in wheat, barley, and rye, and celiac disease is associated with HLA-DQ2 and HLA-DQ8. Just remember, I ate, 2, much gluten at Dairy Queen. It commonly affects individuals of Northern European descent, and the primary site of involvement is the distal duodenum and/or proximal jejunum, which leads to malabsorption and steatorrhea. Treatment for celiac disease is a gluten-free diet, which helps reverse the damage and relieve symptoms. Now listen carefully, because the microscopic findings are critical for diagnosis. Healthy villi become flattened, resulting in villus atrophy, along with crypt hyperplasia and an increase in intraepithelial lymphocytes. Gluten is broken down into gliadin, which becomes deamidated gliadin, then presented by antigen-presenting cells through HLA-DQ2 or DQ8 molecules, which triggers the immune cascade. Tissue transglutaminase, or TTG, is a key autoantigen, and the resulting immune response includes B cells and T cells, releasing cytokines like IFN-gamma and IL-21. This process leads to more intraepithelial lymphocytes, destruction of villi, and mucosal atrophy. Antibodies found in celiac disease include anti-TTG, antideamidated gliadin, and anti-endometrial antibodies. The D-xylose test is abnormal, and histology reveals loss of villi, crypt hyperplasia, and intraepithelial lymphocytosis. Now let's shift gears and discuss lactose intolerance, which results from lactase deficiency, and has a different mechanism. The villi appear normal unless the deficiency is secondary to an injury at the tips, such as from viral enteritis. Symptoms include osmotic diarrhea and a decrease in stool pH, due to fermentation of lactose by colonic bacteria. The lactose hydrogen breath test is positive for lactose malabsorption if the post-lactose hydrogen value increases more than 20 parts per million compared to baseline. Now let's turn to pancreatic insufficiency, which can result from chronic pancreatitis, cystic fibrosis, or an obstructing cancer. This condition leads to malabsorption of fat-soluble vitamins, A, D, E, and K, and also vitamin B12. There is a decrease in duodenal bicarbonate and pH, and fecal elastase levels are reduced, which supports the diagnosis. Unlike celiac disease, the D-xylose test is normal in pancreatic insufficiency, because the mucosa remains intact. Now let's move on to tropical sprue, which shows similar findings to celiac sprue and also affects the small bowel, but the cause remains unknown. What's unique is that it responds to antibiotics and is usually seen in residents of, or recent visitors to, tropical regions. It leads to reduced mucosal absorption, initially affecting the duodenum and jejunum, but with time, the ileum can also be involved. This condition is associated with megaloblastic anemia, first due to folate deficiency and later due to vitamin B12 deficiency. Finally, let's talk about Whipple disease, which is caused by infection with Tropharima whipplei, an intracellular gram-positive organism. Histologically, you'll see PS-positive foamy macrophages in the intestinal lamina propria, and this is a key diagnostic feature. The disease presents not only with diarrhea and steatorrhea but also with cardiac symptoms, arthralgias, and neurologic symptoms, which often come earlier in the disease course. Diarrhea and fat malabsorption tend to occur later, making early recognition based on systemic features vital. It is most common in older males, and you should always think of Whipple disease when these multi-system symptoms occur together. Remember this phrase, PAS the foamy whipped cream, to help recall the pathologic findings and infectious origin. Now let's explore inflammatory bowel diseases, starting with Crohn's disease and ulcerative colitis, which are distinct in location, morphology, and complications. Crohn's disease can involve any portion of the GI tract, though it usually affects the terminal ileum and colon, and it features skip lesions with rectal sparing. In contrast, ulcerative colitis means colon inflammation, with continuous colonic lesions that always include rectal involvement. When we look at gross morphology, Crohn's disease shows transmural inflammation that can lead to fistulas, cobblestone mucosa, creeping fat, and bowel wall thickening. You might also see a string sign on small bowel follow-through, along with linear ulcers and fissures. Ulcerative colitis, on the other hand, has inflammation limited to the mucosa and submucosa, and it causes friable mucosa with superficial and deep ulcerations. Now listen carefully, because this also results in a loss of haustra, which gives a lead pipe appearance on imaging. Moving to microscopic morphology, Crohn's disease features non-caseating granulomas and lymphoid aggregates, while ulcerative colitis shows crypt abscesses and ulcers, with bleeding but no granulomas. Regarding complications, Crohn's disease can lead to malabsorption and malnutrition, and both diseases increase the risk of colorectal cancer, especially with pancolitis. Crohn's disease may also result in fistulas, such as entrovesical fistulae, which can cause recurrent urinary tract infections and pneumaturia. Other complications include phlegmon, abscess, strictures that cause obstruction, and perianal disease. Ulcerative colitis, in severe cases, can lead to fulminant colitis, toxic megacolon, and even perforation. Now let's talk about intestinal manifestations, where Crohn's disease presents with diarrhea that may or may not be bloody, while ulcerative colitis causes bloody diarrhea that is usually painful. Both conditions can present with extraintestinal manifestations, such as rashes like pyoderma gangrenosum and erythema nodosum, and eye inflammation including episcleritis and uveitis. You may also see oral ulcerations, known as aphthous stomatitis, and arthritis that can be peripheral or involve the spine, as spondylitis. In Crohn's disease, inflammation can lead to fat malabsorption, causing calcium to bind fat instead of oxalate, which increases free oxalate absorption, resulting in calcium oxalate kidney stones. Gallstones can also occur. Crohn's disease may test positive for anti-Saccharomyces cerevisiae antibodies, or ASCA. Now let's shift to ulcerative colitis, which is associated with primary sclerosing cholangitis and is often positive for MPNCA, also called PNCA. Treatment for Crohn's disease includes glucocorticoids, azathioprine, antibiotics like ciprofloxacin and metronidazole, and biologics such as infliximab and adalimumab. For ulcerative colitis, treatment may include 5-aminosalicylic acid preparations like mesalamine, immunosuppressants like 6-mercaptopurine, infliximab, and in some cases, colectomy. These therapies help manage inflammation, reduce flares, and prevent complications, though each disease responds differently depending on the extent and severity of involvement. Disease activity in both Crohn's disease and ulcerative colitis can be monitored using fecal calprotectin, which also helps distinguish these conditions from non-inflammatory diseases like irritable bowel syndrome. Now before we finish, let's not forget microscopic colitis, which is another inflammatory disease of the colon, causing chronic watery diarrhea, and it is most common in older females. On endoscopy, the colonic mucosa appears normal, which can be misleading, so biopsy is essential for diagnosis. Histology reveals a lymphocytic infiltrate in the lamina propria, with intraepithelial lymphocytosis or a thickened subepithelial collagen band. Now let's talk about irritable bowel syndrome, which is defined as recurrent abdominal pain, associated with two or more of the following, related to defecation, change in stool frequency, or change in the form, meaning the consistency, of stool. There are no structural abnormalities, and it is most common in middle-aged females. Chronic symptoms may show up as diarrhea predominant, constipation predominant, or a mixed pattern. The pathophysiology here is multifaceted, and it may be associated with fibromyalgia and mood disorders, including anxiety and depression. First-line treatment involves lifestyle modification and dietary changes, with symptom-based approaches. Now let's focus on appendicitis, which is an acute inflammation of the appendix, and it can be due to obstruction by fecalith in adults, or lymphoid hyperplasia in children. The sequence starts with proximal appendiceal lumen obstruction, leading to closed-loop obstruction, then rising intraluminal pressure, and stimulation of visceral afferent nerve fibers at T8 to T10. This causes an initial diffuse periumbilical pain, which later localizes to the right lower quadrant, at McBurney point, when the inflammation irritates the parietal peritoneum. Symptoms often include nausea, fever, and a risk of perforation, which may lead to peritonitis. You may find psoas, obturator, and Rovseeing signs, where palpation of the left lower quadrant causes severe right lower quadrant pain. On exam, there may be guarding, rebound tenderness, and the treatment is appendectomy. Now listen carefully. Diverticula of the GI tract are blind pouches protruding from the alimentary tract, that still communicate with the gut lumen. Most diverticula found in the esophagus, stomach, duodenum, or colon, are acquired and are known as false diverticula. A true diverticula means all gut wall layers out pouch, such as in Meckel's diverticulum. In contrast, a false diverticulum, or pseudodiverticulum, includes only mucosa and submucosa, pushing through the wall. These usually occur at points where the vasa recta penetrate the muscularis externa layer, like in Zenker's diverticulum. Now let's move to diverticulosis, which involves many false diverticula, commonly in the sigmoid colon, and is found in about 50% of people over 60. It's caused by increased intraluminal pressure, and focal weakness in the colonic wall, often associated with obesity, and diets low in fiber, but high in total fat and red meat. It's often asymptomatic, or it may bring vague discomfort, and may go unnoticed until complications arise. One such complication is painless hematochezia, meaning bright red rectal bleeding. Another possible complication is diverticulitis, which we will now discuss. So keep listening, as we go deeper. Now, diverticulitis refers to inflammation of the diverticula, and it's characterized by wall thickening and typically causes left lower quadrant pain, along with fever and leukocytosis. Uncomplicated cases are managed with supportive care, while complicated ones may require antibiotics. Complications can include abscess formation, fistula, such as a colovesical fistula leading to pneumaturia, obstruction due to inflammatory stenosis, and perforation, which can result in peritonitis. Hematochezia is rare in diverticulitis, although possible in diverticulosis. Now let's talk about Zenker diverticulum, which is a pharyngoesophageal false diverticulum, resulting from esophageal dysmotility that causes herniation of mucosal tissue. This happens at an area of weakness between the thyropharyngeal and cricopharyngeal parts of the inferior pharyngeal constrictor, known as the Killian triangle. Presenting symptoms include dysphagia, obstruction, gurgling, aspiration, foul breath, and a neck mass. It is most commonly found in older males, and it reflects a pulsion mechanism. The location and dysfunction contribute to food trapping and regurgitation. Patients may notice worsening symptoms when lying down or during swallowing. Now listen carefully as we continue with another diverticulum. Meckel diverticulum is a true diverticulum, and it results from the persistence of the vitelline, or omphallomesenteric, duct. It may contain ectopic acid-secreting gastric mucosa and sometimes pancreatic tissue. This is the most common congenital anomaly of the gastrointestinal tract, and it can cause painless hematochezia, melena, right lower quadrant pain, intussusception, volvulus, or obstruction near the terminal ileum. Diagnosis is made using a technetium-99m pertechnetate scan, also called the Meckel scan, which detects uptake by heterotopic gastric mucosa. You should remember the rule of 2 of Meckel diverticulum, 2 times as likely in males, 2 inches long, 2 feet from the ileocecal valve, present in 2% of the population. Commonly presents in the first 2 years of life and may contain 2 types of epithelia, gastric and pancreatic. Now listen carefully. Hirschsprung disease is a congenital megacolon characterized by the absence of ganglion cells, affecting the enteric nervous plexuses, which include Auerbach and Meissner. This condition results from failure of neural crest cell migration, and it's associated with loss of function mutations in the RET gene. It presents with bilious emesis, abdominal distension, and failure to pass meconium within the first 48 hours of life, later progressing to chronic constipation. The normal colon segment proximal to the aganglionic portion becomes dilated, producing a characteristic transition zone. The risk is increased in patients with Down syndrome. Explosive expulsion of feces, known as the squirt sign, may occur during rectal exam, revealing an empty rectum. Diagnosis is made by rectal suction biopsy showing absence of ganglion cells, and treatment is surgical resection. Are you following me? Now let's talk about malrotation, an anomaly in midgut rotation during fetal development, which leads to improper positioning of the bowel. The small bowel becomes clumped on the right side, and the colon is displaced to the left, while fibrous Ladd bands may form. This condition can lead to volvulus and duodenal obstruction, which are serious complications. Symptoms in neonates can include bilious vomiting, abdominal distension, and signs of bowel obstruction. Prompt diagnosis and surgical correction are essential to prevent ischemia. This anomaly alters the natural arrangement of the intestines and predisposes to twisting. Let's continue, as we now focus on intussusception. Intussusception is the telescoping of a proximal bowel segment into a distal one, most often occurring at the ileocecal junction. It is typically seen in infants, and while usually idiopathic, it is less frequently due to an identifiable lead point. The idiopathic form is often associated with recent viral infections, such as adenovirus, and rotavirus vaccination, which may cause Peyer's patch hypertrophy acting as a lead point. Common lead points in children include Meckel diverticulum and small bowel wall hematomas from IgA vasculitis, while adults may have intraluminal masses or tumors. This condition causes small bowel obstruction and vascular compromise, leading to intermittent abdominal pain, vomiting, and bloody currant jelly stools. A sausage-shaped mass may be felt in the right abdomen, and patients often draw their legs to the chest to ease the pain. Ultrasound or CT can show a target sign confirming the diagnosis. Now listen carefully. Volvulus is the twisting of a portion of the bowel around its mesentery, which can lead to obstruction and infarction. This condition can occur throughout the gastrointestinal tract and presents differently based on location and age. Gastric volvulus is more common in adults with paraesophageal hernias, and it presents with severe abdominal pain, dry heaving, and an inability to pass a nasogastric tube. Midgut volvulus occurs more frequently in infants and children, while sigmoid volvulus, which shows a coffee bean sign on X-ray, is more common in older adults. Are you still with me? Now finally, short bowel syndrome is the inability to adequately absorb nutrients in the small intestine, secondary to significant surgical resection. Causes include Crohn's disease, malignancy, or trauma, all of which may require removal of large portions of bowel. Malabsorption occurs especially with bile salts and fats at the distal ileum, leading to postprandial voluminous diarrhea, dehydration, weight loss, and anemia. There may also be formation of calcium oxalate kidney stones due to altered fat absorption. Now let's begin with acute mesenteric ischemia, which is a critical blockage of intestinal blood flow, most often due to embolic occlusion of the superior mesenteric artery. This leads to small bowel necrosis and presents with abdominal pain that is out of proportion to physical findings. Patients may also exhibit red, currant jelly stools, a serious warning sign of intestinal compromise. Risk factors include atrial fibrillation, peripheral arterial disease, recent myocardial infarction, and congestive heart failure. Now let's talk about angiodysplasia, which involves tortuous dilation of vessels that can result in hematochezia. It is most often located in the right-sided colon and tends to be more common in older patients. Diagnosis is confirmed by angiography, especially when bleeding is intermittent. Angiodysplasia is associated with several conditions including end-stage renal disease, von Willebrand disease, and aortic stenosis. These fragile vessels are prone to rupture and may cause recurrent bleeding. It is often asymptomatic until bleeding occurs. Let's keep going with chronic intestinal disorders. Chronic mesenteric ischemia is often called intestinal angina, and it results from atherosclerosis affecting arteries such as the celiac, superior mesenteric, or inferior mesenteric arteries. This leads to intestinal hypoperfusion, particularly after meals, resulting in postprandial epigastric pain. Patients may develop food aversion and progressive weight loss due to fear of eating. Another condition, colonic ischemia, presents as crampy abdominal pain followed by hematochezia and typically affects older adults. It commonly occurs at watershed areas like the splenic flexure and rectosigmoid junction, where blood supply is more vulnerable. Imaging often shows a thumbprint sign due to mucosal edema or hemorrhage. Now listen motherfuckers, ileus is intestinal hypomotility without obstruction, leading to constipation and reduced flatus, accompanied by a distended and tympanic abdomen with diminished bowel sounds. It is associated with abdominal surgeries, opiate use, hypokalemia, and sepsis. Imaging shows no transition zone, which helps differentiate it from mechanical obstruction. Treatment includes bowel rest, correction of electrolytes, and administration of cholinergic drugs to stimulate motility. It is a functional disorder, not a blockage, but can mimic obstruction clinically. Necrotizing enterocolitis is a devastating condition seen in premature, formula-fed infants with immature immune systems. It involves necrosis of the intestinal mucosa, most commonly affecting the terminal ileum and proximal colon. Complications include pneumatosis intestinalis, pneumoperitoneum, and portal venous gas, all visible on imaging. You should remember this. Proctitis refers to inflammation of the rectal mucosa, often due to infection from organisms such as Neisseria gonorrhea, chlamydia, campylobacter, shigella, salmonella, HSV, or CMV. It can also occur with inflammatory bowel disease or after radiation exposure. Patients typically report tenesmus, rectal bleeding, and rectal pain. Proctoscopy reveals inflamed mucosa, and in cases of HSV, ulcers or vesicles may be seen. Rectal swabs help identify the infectious cause. Let's move on to another critical bowel disorder. Small bowel obstruction occurs when the normal flow of intraluminal contents is interrupted, leading to fluid accumulation and dilation proximal to the blockage, and decompression distally. It presents with abrupt abdominal pain, nausea, vomiting, and distension. If blood flow is compromised, ischemia, necrosis, or perforation may follow. Most common causes include intraperitoneal adhesions, tumors, and hernias. In newborns, meconium ileus may be responsible. Upright abdominal X-ray shows air fluid levels, and management includes decompression, fluids, and bowel rest. Now listen carefully, we'll finish with one more. Small intestinal bacterial overgrowth involves abnormal bacterial colonization in the small intestine, which normally has a low bacterial count. Risk factors include altered pH like achlorhydria or PPI use, anatomical abnormalities such as adhesions, fistulas, or bypass surgeries, dysmotility like gastroparesis, and immune deficiencies like IgA deficiency or HIV. Symptoms include bloating, flatulence, abdominal pain, chronic watery diarrhea, and in severe cases, malabsorption of vitamin B12. Diagnosis is made using a carbohydrate breath test or by direct culture from small bowel aspirates. Colonic polyps, growths of tissue within the colon, are grossly characterized as flat, sessile, or pedunculated, based on their protrusion into the colonic lumen, and are generally classified by histologic type. Now let's talk about the histologic type characteristics, beginning with the generally non-neoplastic ones. Hamartomatous polyps are solitary lesions that do not have a significant risk of transformation. They are growths of normal colonic tissue with distorted architecture, and they are associated with Peutz-Jeghers syndrome and juvenile polyposis. Hyperplastic polyps, which are the most common, are generally smaller and predominantly located in the rectosigmoid region, and occasionally, they evolve into serrated polyps and more advanced lesions. Inflammatory pseudopolyps arise due to mucosal erosion in inflammatory bowel disease, while mucosal polyps are small, usually less than 5 mm, and look similar to normal mucosa, making them clinically insignificant. Submucosal polyps may include lipomas, leiomyomas, fibromas, and other lesions, but now let's talk about those that are potentially malignant. Adenomatous polyps are neoplastic, developing via the chromosomal instability pathway with mutations in APC and KRAS, and while tubular histology has less malignant potential than villus, hence the saying, villus histology is villainous. The tubulovillus type has an intermediate malignant potential, and though usually asymptomatic, they may present with occult bleeding. Serrated polyps, also neoplastic, are characterized by the CpG island methylator phenotype, which involves a cytosine base followed by guanine, linked by a phosphodiester bond. This defect may silence mismatch repair gene expression, such as MLH1, and mutations lead to microsatellite instability and BRAF mutations, with a characteristic sawtooth pattern of crypts on biopsy, accounting for up to 20% of sporadic CRC cases. Now let's continue with polyposis syndromes, beginning with familial adenomatous polyposis, which is an autosomal dominant mutation of the APC tumor suppressor gene located on chromosome 5q21 to q22, following the two-hit hypothesis. Thousands of polyps begin to arise after puberty, with pancolonic distribution, always involving the rectum, and without prophylactic colectomy, this condition progresses to colorectal cancer in 100% of cases. Gardner syndrome is familial adenomatous polyposis combined with osseous and soft tissue tumors, such as osteomas of the skull or mandible, along with congenital hypertrophy of the retinal pigment epithelium, and impacted or supernumerary teeth. Tickett syndrome, on the other hand, is a combination of familial adenomatous polyposis or Lynch syndrome with malignant central nervous system tumors, including medulloblastoma or glioma, so just remember, Tickett equals turban, symbolizing brain tumors. Peutz-Jeghers syndrome is an autosomal dominant condition marked by numerous hamartomatous polyps throughout the gastrointestinal tract, and is also noted for hyperpigmented macules on the mouth, lips, hands, and genitalia, while being associated with an increased risk of cancers such as breast, colorectal, stomach, small bowel, and pancreatic. Juvenile polyposis syndrome, usually seen in children under 5 years of age, is another autosomal dominant condition, featuring numerous hamartomatous polyps located in the colon, stomach, and small bowel, and this condition too is associated with an increased risk of colorectal cancer. Finally, we reach muti-associated polyposis syndrome, which is an autosomal recessive disorder involving the muti gene responsible for DNA repair, and it's associated with a significantly increased risk of colorectal cancer, adenomatous polyps that may also be hyperplastic or serrated, as well as serrated adenomas. Additionally, this syndrome is linked to duodenal adenomas, and cancers of the ovary and bladder, making early recognition and genetic counseling essential for management. Lynch syndrome, also called hereditary non-polyposis colorectal cancer or HNPCC, is an autosomal dominant mutation of mismatch repair genes, such as MLH1 and MSH2, which results in microsatellite instability, and approximately 80% of cases progress to colorectal cancer. The proximal colon is always involved, and this condition is associated with endometrial, ovarian, and skin cancers. Just remember, Merrill Lynch has COs. Now let's talk about colorectal cancer, beginning with its epidemiology, where most patients are older than 50 years, and around 25% have a family history. As for risk factors, they include adenomatous and serrated polyps, familial cancer syndromes, inflammatory bowel disease, tobacco use, and a diet rich in processed meat but low in fiber. Presentation tends to follow a pattern, with rectosigmoid involvement being the most common, followed by the ascending and then descending colon, and while most cases remain asymptomatic, the right side, which includes the cecum and ascending colon, is associated with occult bleeding, while the left side, particularly the rectosigmoid, is linked to hematochezia and obstruction due to its narrower lumen, which also results in reduced stool caliber. An ascending colon cancer typically forms an exophytic mass, and may present with iron deficiency anemia and weight loss, whereas a descending colon cancer forms an infiltrating mass, leads to partial obstruction, causes colicky pain, and is often accompanied by hematochezia. In some cases, it may even present with Streptococcus bovis, also called Galolyticus, bacteremia or endocarditis, or mimic an episode of diverticulitis. Now listen carefully, because when it comes to diagnosis, iron deficiency anemia in males, especially those older than 50 years, and in postmenopausal females, raises clinical suspicion. For screening, the average risk population should begin at age 45 with colonoscopy, where a polyp might be seen, as shown in image A, though alternatives include flexible sigmoidoscopy, fecal occult blood testing or FOBT, fecal immunochemical testing known as FIT fecal DNA combination testing, and CT colonography. Patients with a first-degree relative diagnosed with colon cancer should be screened earlier, starting at age 40 with colonoscopy, or 10 years before the age at which the relative was diagnosed. And for those with inflammatory bowel disease, screening should start 8 years after onset. An apple core lesion may be visible on a barium enema X-ray, as depicted in image B. The carcinoembryonic antigen, or CEA tumor marker, is useful for monitoring recurrence, but it should not be used for screening purposes. Now let's explore the molecular pathogenesis of colorectal cancer, beginning with the chromosomal instability pathway, in which mutations in the APC gene are responsible for familial adenomatous polyposis and the majority of sporadic colorectal cancer cases, commonly those that are left-sided, through the classic adenomatocarcinoma sequence. On the other hand, the microsatellite instability pathway involves mutations or methylation of mismatch repair genes such as MLH1, leading to Lynch syndrome and some sporadic colorectal cancers, which are commonly right-sided and progress through the serrated polyp pathway. Overexpression of COX-2 has also been linked to colorectal cancer, and nonsteroidal anti-inflammatory drugs, or NSAIDs, may offer a chemopreventive benefit. So, the chromosomal instability pathway follows this sequence. First, there is loss of the APC gene, followed by KRAS mutation, and later, the loss of tumor suppressor genes such as TP53 and DCC, leading from a normal colon with preserved intercellular adhesion, to unregulated intracellular signaling, and eventually to tumorigenesis. Now let's talk about cirrhosis and portal hypertension, beginning with cirrhosis itself, which involves diffuse bridging fibrosis caused by stellate cells, along with regenerative nodules that disrupt the normal architecture of the liver, as shown in Image A, and this disruption significantly increases the risk for hepatocellular carcinoma. Cirrhosis can lead to a wide range of systemic changes, and its causes include alcohol use, non-alcoholic steatohepatitis, chronic viral hepatitis, autoimmune hepatitis, biliary diseases, and several genetic or metabolic disorders. Moving on to portal hypertension, it refers to increased pressure in the portal vein system, which leads to the formation of new collateral circulation and dilation of collateral vessels, resulting in varices, particularly esophageal, gastric, and rectal. The most common cause of portal hypertension is cirrhosis, although other causes include schistosomiasis and portal vein thrombosis. Now listen carefully. Ascites refers to the pathological accumulation of fluid in the peritoneal cavity, and it may arise from portal hypertension or portal vein thrombosis. Increased hepatic sinusoidal pressure leads to acidic fluid buildup, and diagnosis involves a serum to ascites albumin gradient, or SAAG, analysis of the fluid. A SAAG value greater than or equal to 1.1 indicates portal hypertension as the underlying cause. Now let's explore the systemic effects of portal hypertension across different organ systems. In the integumentary system, signs include jaundice, spider angiomas, palmar erythema, purpura, and petechiae. From a neurologic standpoint, hepatic encephalopathy may develop, and it's often accompanied by hysterexis, which is a characteristic flapping tremor of the hands. Gastrointestinal consequences include esophageal and gastric varices, which can present with hematemesis or melena due to variceal bleeding. Reproductive effects are also prominent, including testicular atrophy, gynecomastia in males, and amenorrhea in females. Vascular changes include caput medusae, those dilated veins radiating from the umbilicus, as well as anorectal varices. Ascites, which we've already discussed, can also lead to spontaneous bacterial peritonitis, a serious and potentially life-threatening complication. Splenomegaly is another result of increased portal pressure. Moving on to gastrointestinal symptoms more broadly, patients may experience anorexia, nausea, vomiting, dull abdominal pain, and fetor hepaticus, which is a musty odor of the breath due to volatile compounds in liver failure. Now listen closely. Hematologic effects include thrombocytopenia, anemia, and disorders of coagulation, all of which may result from impaired liver synthesis of clotting factors and sequestration of platelets in an enlarged spleen. Metabolic complications are common as well, including hyperbilirubinemia and hyponatremia. Finally, renal effects include the development of hepatorenal syndrome, a functional kidney failure secondary to advanced liver disease, and the cardiovascular system may also be affected, leading to cardiomyopathy and other complications. Now listen carefully as we dive into Budd-Chiari syndrome, which is defined as hepatic venous outflow tract obstruction, and this can be due to thrombosis or external compression. The result is centrilobular congestion and necrosis, which leads to congestive liver disease, and you'll often find hepatomegaly, ascites, varices, abdominal pain, and even liver failure. A distinguishing feature is the absence of jugular venous distension, or JVD, despite the significant hepatic congestion. Budd-Chiari syndrome is strongly associated with hypercoagulable states like polycythemia vera, the postpartum period, and hepatocellular carcinoma, or HCC. On gross examination, the liver may take on a mottled appearance referred to as nutmeg liver. Now let's shift to portal vein thrombosis, which refers to thrombosis occurring in the portal vein proximal to the liver. Most patients remain asymptomatic, but it can still lead to complications such as portal hypertension, abdominal pain, and fever. If the thrombosis extends into the superior mesenteric vein, it can result in bowel ischemia. This condition may arise due to cirrhosis, malignancy, pancreatitis, or systemic infections like sepsis. Remember, Budd-Chiari often presents with hepatosplenomegaly, while portal vein thrombosis does not cause hepatomegaly unless there is already pre-existing liver disease. Now let's talk about spontaneous bacterial peritonitis, also called primary bacterial peritonitis, which is a common and potentially fatal infection that occurs in patients with cirrhosis and ascites. This infection can be sneaky, often asymptomatic, but may still cause fever, chills, abdominal pain, ileus, or worsening hepatic encephalopathy. The most frequent culprits are gram-negative organisms like E. coli and Klebsiella, while gram-positive Streptococcus species are less common offenders. Diagnosis requires paracentesis, and an absolute neutrophil count greater than 250 cells per cubic millimeter in the acidic fluid confirms the infection. The first-line empirical treatment is a third-generation cephalosporin, such as ceftriaxone. Now that we've covered this, let's move on to the serum markers that reveal liver pathology. So, are you ready to understand how enzymes and functional markers reflect liver damage? First, let's look at the enzymes released during hepatocellular injury, particularly aspartate aminotransferase, or AST, and alanine aminotransferase, or ALT. In most types of liver disease, ALT tends to rise higher than AST. However, in alcoholic liver disease, AST is usually greater than ALT, typically with a ratio exceeding 2 to 1, and it rarely exceeds 500 units per liter. Just remember, make a toast with alcohol. Interestingly, an AST greater than ALT in non-alcoholic liver disease may indicate progression to advanced fibrosis or cirrhosis. Very high aminotransferase levels, usually greater than 1,000 units per liter, suggest acute liver insults such as drug-induced liver injury, ischemic hepatitis, acute viral hepatitis, or autoimmune hepatitis. Next, alkaline phosphatase, or ALP, is increased in cholestatic conditions like biliary obstruction, as well as in infiltrative diseases and certain bone disorders. Now listen carefully as we talk about gamma-glutamyl transpeptidase, or GGT, which also rises in liver and biliary diseases just like ALP does, but it's not elevated in bone disease. GGT is located in the canalicular membranes of hepatocytes, and its elevation is especially linked with alcohol use. Shifting now to functional markers of liver health, bilirubin is elevated in many liver diseases including biliary obstruction, alcoholic or viral hepatitis, and cirrhosis, and it also increases during hemolysis. Albumin levels drop in advanced liver disease, serving as a marker of the liver's biosynthetic capacity. The prothrombin time is prolonged when liver function declines, due to reduced synthesis of clotting factors, making it another critical biosynthetic measure. Finally, platelet counts tend to fall in advanced liver disease due to reduced thrombopoietin production and sequestration in the spleen, which is often enlarged because of portal hypertension. Now listen carefully as we explore Reye syndrome, which is a rare but often fatal condition in children, involving hepatic encephalopathy. It's typically associated with a recent viral infection, especially varicella-zoster virus or influenza, that has been treated with aspirin. The problem lies in aspirin's metabolites, which inhibit mitochondrial enzymes reversibly, thereby reducing beta-oxidation. This leads to mitochondrial abnormalities and the development of fatty liver changes, particularly microvesicular steatosis. Alongside this, children may present with hyperammonemia, severe hypoglycemia, vomiting, hepatomegaly, and eventually coma. As intracranial pressure increases, so does the risk of death or lasting complications, and both renal and cardiac failure can occur. It's vital to avoid giving aspirin to children, except in specific cases like Kawasaki disease. Just remember this, salicylates aren't a ray, or rye, of sunshiny for kids, and that acronym reminds you, S for steatosis, H for hypoglycemia and hepatomegaly, I for infection, N for not awake or coma, and E for encephalopathy with diffuse cerebral edema. Now let's talk about alcoholic liver disease, which begins with excess NADH production, inhibiting fatty acid oxidation while increasing lipogenesis. This imbalance promotes fat accumulation in hepatocytes, resulting in hepatic steatosis, a macrovesicular fatty change that is still reversible with alcohol cessation. But if alcohol consumption is sustained long-term, it progresses to alcoholic hepatitis. At this stage, the liver shows swollen, necrotic hepatocytes infiltrated by neutrophils. You'll also find characteristic Mallory bodies. These are eosinophilic cytoplasmic inclusions made of damaged keratin filaments. If drinking continues, the liver enters the final stage known as alcoholic cirrhosis, which is usually irreversible. In early disease, you may see sclerosis around the central vein, but with progression, regenerative nodules become surrounded by fibrous bands, a response to repeated liver injury. These structural changes lead to portal hypertension and eventually end-stage liver disease. Are you following me? Because now we move to steatotic liver disease, or SLD, a broader term that includes metabolic dysfunction-associated SLD, or MASLD. This was previously called non-alcoholic fatty liver disease. It also includes MASLD with alcohol use, alcohol-associated liver disease, SLD from specific causes, and cryptogenic SLD. MASLD is closely tied to features of metabolic syndrome, including obesity, insulin resistance, hypertension, hypertriglyceridemia, and low HDL levels. Obesity contributes to fatty infiltration in hepatocytes, leading to cellular ballooning and, in some cases, hepatocyte necrosis. Importantly, steatosis occurs without significant inflammation or fibrosis at first and may even regress if the underlying metabolic issues are addressed. Most patients remain asymptomatic in this phase. However, if inflammation becomes prominent, it evolves into metabolic dysfunction-associated steatohepatitis, which includes lobular inflammation and hepatocyte ballooning. This condition increases the risk for fibrosis, and over time, it can progress further to cirrhosis or hepatocellular carcinoma. Now listen carefully as we begin with autoimmune hepatitis, a chronic inflammatory liver disease that occurs more commonly in females. It can be completely silent or may present with symptoms like fatigue, nausea, and generalized itching. The condition is often linked to autoantibodies, especially anti-smooth muscle and anti-liver/kidney microsomal 1 antibodies. Lab findings typically show elevated ALT and AST levels, and histologic examination reveals portal and periportal lymphoplasmacytic infiltrates. Are you ready to talk about hepatic encephalopathy? This condition arises when cirrhosis causes the formation of portosystemic shunts, which reduce ammonia metabolism and allow neurotoxic substances to reach the brain. What follows is a spectrum of reversible neuropsychiatric dysfunction, ranging from disorientation and hysterexis, to difficulty in arousal, or even coma. There are key triggers, such as increased ammonia production and absorption due to gastrointestinal bleeding, constipation, or infections. Also, reduced ammonia clearance may occur due to renal failure, diuretic use, or post-TIPS procedures that bypass the liver. Treatment aims to reduce ammonia levels, using lactulose to increase ammonium generation, and rifaximin to suppress gut bacteria that produce ammonia. Prompt treatment can reverse symptoms and prevent progression to coma. Now let's talk about liver tumors, beginning with hepatic hemangioma, the most common benign liver tumor, also known as a cavernous hemangioma. It usually presents in adults aged 30 to 50 and consists of venous malformations. These tumors are often detected incidentally, and biopsy should be avoided due to the risk of severe bleeding. Next, we have focal nodular hyperplasia, the second most common benign liver tumor, which is seen mostly in women between the ages of 35 and 50. It's a hyperplastic response of hepatocytes to a malformed artery, and it typically contains a central stellate scar. While these lesions are usually asymptomatic, they're found during imaging for unrelated reasons. Are you following me? Because now we move on to hepatic adenoma, a rare but benign tumor that's commonly linked to the use of oral contraceptives or anabolic steroids. These tumors might regress on their own, but in some cases, they can rupture and lead to abdominal pain and even hemorrhagic shock. More seriously, we come to hepatocellular carcinoma, also called hepatoma, which is the most common primary malignant liver tumor in adults. It's associated with chronic liver diseases like hepatitis B and C, alcoholic and non-alcoholic fatty liver disease, autoimmune liver disease, hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency, as well as with exposure to aflatoxins from Aspergillus. Now let's finish strong with how hepatocellular carcinoma presents. Patients may have anorexia, jaundice, or tender hepatomegaly, and it may cause sudden decompensation in those with previously stable cirrhosis, leading to ascites or portal vein thrombosis. It spreads through the bloodstream, and the diagnostic approach includes screening with ultrasound and confirmation using contrast-enhanced CT or MRI. If the imaging is unclear, a biopsy may be needed. Serum alpha-fetoprotein, AFP, is used for monitoring recurrence. Finally, we briefly mention hepatic angiosarcoma, a rare and malignant tumor of vascular origin linked to arsenic and vinyl chloride exposure, and liver metastases, which are the most common malignant tumors in the liver overall. These usually come from cancers in the GI tract, breast, or lungs, and are rarely solitary. Now listen carefully. Alpha-1 antitrypsin deficiency begins with a misfolded gene product, and these abnormal proteins aggregate inside the hepatocellular endoplasmic reticulum, leading to cirrhosis. On histology, you'll find PS-positive globules in the liver, and the condition follows a codominant inheritance pattern. Clinically, it often presents in young individuals who show signs of liver damage and shortness of breath, even though they have no history of tobacco use. In the lungs, the reduced alpha-1 antitrypsin allows elastase to go unchecked, which destroys elastic tissue in the alveoli and causes panaciner emphysema. Now let's talk about jaundice, which is an abnormal yellow discoloration of the skin and the sclera, also called icterus, and it's due to bilirubin being deposited in tissues. This occurs when there is hyperbilirubinemia, which can result from either increased bilirubin production or decreased clearance, such as impaired hepatic uptake, defective conjugation, or reduced excretion. A helpful memory aid is hot liver, which reminds us of the common causes of elevated bilirubin, hemolysis, obstruction, tumor, and liver disease. Are you following me? Because now we look at conjugated hyperbilirubinemia, also called direct hyperbilirubinemia, which arises from biliary tract obstructions like gallstones, cholangiocarcinoma, pancreatic or liver cancers, and liver fluke infestations. It may also occur in diseases of the biliary tract, such as primary sclerosing cholangitis or primary biliary cholangitis. Another cause involves excretion defects, including genetic conditions like Dubin-Johnson syndrome or Rotor syndrome. Let's move to unconjugated or indirect hyperbilirubinemia, which results from excessive bilirubin production as seen in hemolytic conditions, or from impaired conjugation mechanisms such as in benign neonatal jaundice, Crigler-Najjar syndrome, or Gilbert syndrome. Sometimes patients present with a mixed picture, having both direct and indirect hyperbilirubinemia. This is commonly seen in hepatitis and cirrhosis. Now let's turn to benign neonatal hyperbilirubinemia, which was previously known as physiologic jaundice of the newborn. This mild unconjugated hyperbilirubinemia arises from three main factors. First, increased turnover of fetal red blood cells, which have a higher hematocrit and a shorter lifespan. Second, an immature newborn liver with low activity of UDP-glucuronosyltransferase. And third, a sterile gut that lacks the microbes needed to convert bilirubin into urobilinogen. This allows deconjugation by intestinal brush border beta-glucuronidase, leading to more enterohepatic circulation of unconjugated bilirubin. Now let's finish this section with breastfeeding failure jaundice and breast milk jaundice. Breastfeeding failure jaundice results from inadequate milk intake, which decreases bilirubin elimination in the stool and increases enterohepatic circulation. Breast milk jaundice, on the other hand, results from high levels of beta-glucuronidase in the milk itself, which deconjugates bilirubin in the intestine and leads to more reabsorption. In both cases, unconjugated bilirubin rises and can, in severe situations, lead to kernicterus, where lipid-soluble bilirubin deposits in the brain, especially the basal ganglia. Fortunately, treatment with phototherapy, non-UV light that changes bilirubin into a water-soluble form, can prevent this complication effectively. Now let's talk about biliary atresia, which stands as the most common reason for pediatric liver transplantation, and it is marked by fibro-obliterative destruction of the bile ducts that leads directly to cholestasis. This condition is often associated with either an absent or abnormally developed gallbladder as seen on ultrasonography. Typically, the newborn presents with persistent jaundice that continues beyond the first 2 weeks of life, and is accompanied by darkening of the urine, pale or acholic stools, and hepatomegaly. Laboratory findings show a rise in direct bilirubin and elevated GGT levels, helping to confirm the diagnosis. Now listen carefully, because we're moving into hereditary hyperbilirubinemias, beginning with Gilbert syndrome, which is a mild condition caused by reduced activity of UDP-glucuronosyltransferase, resulting in impaired conjugation of bilirubin. Individuals with this condition may be asymptomatic or present with mild jaundice, usually triggered by stress, illness, or fasting, and there is an increase in unconjugated bilirubin without evidence of hemolysis. It's a relatively common and benign condition that often requires no treatment. Are you following me? Because now we have Crigler-Najjar syndrome type I, a much more severe disorder in which UDP-glucuronosyltransferase is completely absent. It usually presents early in life with persistent jaundice and can progress to kernicterus, which is the deposition of unconjugated bilirubin in the brain. Lab findings show significantly elevated levels of unconjugated bilirubin. Treatment options include plasmapheresis and phototherapy, although these do not conjugate bilirubin but rather increase its polarity and water solubility to allow excretion. A liver transplant offers a definitive cure. In contrast, type 2 Crigler-Najjar syndrome is less severe and responds to phenobarbital, which boosts liver enzyme synthesis, distinguishing it clearly from type 1. Now let's shift to Dubin-Johnson syndrome, which is characterized by conjugated hyperbilirubinemia due to a defect in liver excretion mechanisms. One of its hallmark features is a grossly black liver, caused by impaired excretion of epinephrine metabolites, although the condition itself is benign. Now listen closely as we discuss Rotor syndrome, which resembles Dubin-Johnson syndrome in presentation but is milder and lacks the black liver appearance. This condition arises from impaired hepatic storage of conjugated bilirubin, leading to its leakage into the blood. The liver looks normal, or regular, which is a useful contrast to the dark liver of Dubin-Johnson. Like Dubin-Johnson, Rotor syndrome is benign, does not cause liver damage, and usually doesn't require treatment. Differentiation between the two can be made with specialized testing if needed, but clinical management remains focused on patient education and reassurance. Now we turn to the hepatic architecture that helps explain bilirubin metabolism. Hemoglobin from red blood cells becomes circulating bilirubin, which is taken up by hepatocytes in a process that begins at the hepatic sinusoid. Kupffer cells, or liver macrophages, process this material, and the bilirubin then enters the space of Diess. From here, the bilirubin travels into the hepatocyte, where it is conjugated by the enzyme UDP-glucuronosyltransferase, converting it into a water-soluble form, bilirubin diglucuronide. This conjugated bilirubin is then transported into the bile canalicular lumen for excretion. Any obstruction downstream in this pathway results in obstructive jaundice, especially when bilirubin cannot flow into the bile ducts. Each step, uptake, conjugation, and excretion, is essential for proper bilirubin handling. Wilson disease, also called hepatolenticular degeneration, is caused by autosomal recessive mutations in the hepatocyte copper-transporting ATPase, specifically the ATP7B gene on chromosome 13, leading to reduced copper incorporation into apoceruloplasmin and impaired excretion into bile, resulting in decreased serum ceruloplasmin, and copper accumulates, especially in the liver, brain such as the basal ganglia, cornea, kidneys, and there is increased copper in the urine, and this condition presents before age 40 with liver disease such as hepatitis, acute liver failure, or cirrhosis, and also with neurologic disease including dysarthria, dystonia, tremor, or Parkinsonism, and psychiatric disease may occur, along with Kaiser-Fleischer rings which are deposits in decimet membrane of the cornea, and hemolytic anemia may also be present, along with renal disease such as Fanconi syndrome, and treatment involves chelation with penicillamine or trientine, or oral zinc, and liver transplant is considered in acute liver failure related to Wilson disease. Now let's talk about hemochromatosis, an autosomal recessive disorder caused by mutation in the HFE gene located on chromosome 6, which leads to abnormal, low hepcidin production and increased intestinal iron absorption, and iron overload can also occur secondary to chronic transfusion therapy, such as in beta thalassemia major, and iron accumulates especially in the liver, pancreas, skin, heart, pituitary, and joints, and hemosiderin or iron can be identified on liver MRI or biopsy using the Prussian blue stain, and this condition usually presents after age 40 when total body iron exceeds 20 grams, and iron loss through menstruation slows progression in females, while the classic triad includes cirrhosis, diabetes mellitus, and skin pigmentation known as bronze diabetes, and it can also cause restrictive cardiomyopathy or dilated cardiomyopathy which is reversible, and may lead to hypogonadism, arthropathy from calcium pyrophosphate deposition especially in the metacarpophalangeal joints, and hepatocellular carcinoma is a common cause of death, and treatment includes repeated phlebotomy, or iron chelation using deferocyrox, deferoxamine, or deferoprone. Now listen carefully. Biliary tract disease may present with pruritus, jaundice, dark urine, light-colored stool, and hepatosplenomegaly, and typically shows a cholestatic pattern of liver function tests including elevated conjugated bilirubin, increased cholesterol, raised alkaline phosphatase, and elevated gamma-glutamyl-transferase, and in primary sclerosing cholangitis. The pathology involves an unknown cause of concentric onion skin bile duct fibrosis, leading to alternating strictures and dilation with a beating pattern of intrahepatic and extrahepatic bile ducts as seen on ERCP or MRCP, and this classically occurs in middle-aged males with ulcerative colitis, and is associated with ulcerative colitis, MPNCA or PNCA positivity, increased IgM, and it can lead to secondary biliary cirrhosis, and there is an increased risk of cholangiocarcinoma and gallbladder cancer. Are you following me? Primary biliary cholangitis is characterized by an autoimmune reaction causing lymphocytic infiltrate with or without granulomas, which leads to destruction of lobular bile ducts, and this condition is classically seen in middle-aged females, and is associated with positive antimitochondrial antibody, elevated IgM, and other autoimmune conditions such as Hashimoto thyroiditis, rheumatoid arthritis, and celiac disease, and the treatment of choice is ursodiol, and now we come to secondary biliary cirrhosis which results from extrahepatic biliary obstruction, leading to increased pressure in intrahepatic ducts causing injury, fibrosis, and bile stasis, and it occurs in patients with known obstructive lesions such as gallstones, biliary strictures, or pancreatic carcinoma, and this condition may be complicated by acute cholangitis. Cholelithiasis and related pathologies, now listen carefully, involve an increase in cholesterol and bilirubin, a decrease in bile salts, and gallbladder stasis, which together cause sludge or stones. There are two main types of stones. First, cholesterol stones, which are usually radiolucent but may appear opaque in 10 to 20% of cases due to calcifications, and they make up 80% of all stones. These are associated with obesity, Crohn's disease, advanced age, estrogen therapy, multiparity, rapid weight loss, medications such as fibrates, and are more common in white and Native American populations. Then, we have pigment stones, which are either black, radiopaque, and composed of calcium bilirubinate, often linked to hemolysis, or brown, which are radiolucent and associated with infections. Pigment stones are connected to Crohn's disease, chronic hemolysis, alcoholic cirrhosis, advanced age, biliary infections, and total parenteral nutrition. Are you following me? The most common complication of cholelithiasis is cholecystitis, but it can also cause acute pancreatitis or acute cholangitis. Diagnosis is done with ultrasound, and if the patient is symptomatic, the treatment is elective cholecystectomy. Now let's talk about the classic risk factors, famously known as the 8 F's, which include female, fat, fertile, 40, fair, feeds, which refers to total parenteral nutrition, fasting from rapid weight loss, and fibrates. Contributing factors involve sex, age, obesity, and genetics, all of which can lower cholesterol 7-alpha hydroxylase. In chronic hemolysis or biliary tract infection, decreased cholesterol and bile salts, combined with gallbladder stasis, result in pigment stones, while unconjugated bilirubin and stasis lead to supersaturation of bile with calcium bilirubinate. Cholesterol stones form when bile is supersaturated with cholesterol, due to similar mechanisms. Now let's move on to the related pathologies, beginning with biliary colic, which is associated with nausea and vomiting and presents as dull right upper quadrant pain. Neurohormonal activation, for example by cholecystokinin after a fatty meal, triggers gallbladder contraction, forcing a stone into the cystic duct. Laboratory values are usually normal, and ultrasound reveals cholelithiasis. Cholelithiasis, on the other hand, is the presence of gallstones in the common bile duct, and it often leads to elevated alkaline phosphatase, GGT, direct bilirubin, and possibly AST or ALT levels. Let's continue with cholecystitis, which is acute or chronic inflammation of the gallbladder. Now listen carefully. Calculous cholecystitis is the most common type, resulting from gallstone impaction in the cystic duct, which leads to inflammation and gallbladder wall thickening, and may cause secondary infection. Acalculous cholecystitis is caused by gallbladder stasis, hypoperfusion, or infection like CMV, and typically occurs in critically ill patients. A positive Murphy sign, where there is inspiratory arrest during right upper quadrant palpation due to pain, may be noted, and pain may radiate to the right shoulder due to phrenic nerve irritation. If the bile duct becomes involved, such as in acute cholangitis, alkaline phosphatase levels increase. Diagnosis involves ultrasound or coloscintigraphy, also known as a HITA scan, where failure to visualize the gallbladder suggests obstruction. Are you ready to hear more? Gallstone ileus occurs when a fistula forms between the gallbladder and the gastrointestinal tract, allowing a stone to enter the GI lumen, which then becomes obstructed at the ileocecal valve, the narrowest point. This condition can present with air in the biliary tree, also known as pneumobilia. Wrigler triad, which consists of radiographic findings of pneumobilia, small bowel obstruction, and a gallstone usually in the iliac fossa, confirms the diagnosis. Porcelain gallbladder is another pathology, characterized by a calcified gallbladder due to chronic cholecystitis, often found incidentally on imaging, and treatment involves prophylactic cholecystectomy due to increased risk of gallbladder cancer, mostly adenocarcinoma. Finally, acute cholangitis, also called ascending cholangitis, is an infection of the biliary tree that usually results from obstruction, leading to stasis and bacterial overgrowth. The Charcot triad of cholangitis includes jaundice, fever, and right upper quadrant pain, while Reynolds pentad adds altered mental status and hypotension, indicating shock, to Charcot triad. Now let's talk about cholangiocarcinoma, a malignant tumor of the bile duct epithelium, and the most common location, which is the convergence of the right and left hepatic ducts. Risk factors include primary sclerosing cholangitis and liver fluke infections, like Clonorchis. This disease usually presents late, with fatigue, weight loss, abdominal pain, and jaundice, while imaging may show biliary tract obstruction. Histologically, you'll find infiltrating neoplastic glands, associated with a desmoplastic stroma, which is important for confirming the diagnosis. Are you ready to dive into pancreatitis, which refers to inflammation of the pancreas and is usually sterile? Let's begin with acute pancreatitis, caused by autodigestion of the pancreas by pancreatic enzymes, and the causes can be remembered by the mnemonic, I get smashed, including idiopathic, gallstones, ethanol, trauma, steroids, mumps, autoimmune disease, scorpion sting, hypercalcemia or hypertriglyceridemia above 1000 mg per deciliter, ERCP, and drugs such as sulfa drugs, NRTIs, and protease inhibitors. Now listen carefully, because diagnosis is made by 2 out of 3 criteria: acute epigastric pain that often radiates to the back, serum amylase or lipase levels that are 3 times the upper limit of normal, or imaging findings that are characteristic. The complications are many, including pancreatic pseudocyst, which is lined by granulation tissue and not epithelium, and others like abscess, necrosis of parenchymal or peripancreatic tissue, hemorrhage, infection, and organ failure such as ALI, ARDS, shock, or renal failure, as well as hypocalcemia due to precipitation of calcium soaps. Now let's talk about chronic pancreatitis, which involves chronic inflammation, atrophy, and calcification of the pancreas. The major risk factors include alcohol use disorder, genetic predispositions such as cystic fibrosis or SPINK1 mutations, and sometimes it can even be idiopathic. Complications include pancreatic insufficiency and the formation of pseudocysts. You should remember this, because pancreatic insufficiency, typically when there's less than 10% pancreatic function, may manifest with steatorrhea, fat-soluble vitamin deficiency, and diabetes mellitus. Amylase and lipase may or may not be elevated in chronic pancreatitis but almost always elevated in acute pancreatitis. And now, we arrive at pancreatic adenocarcinoma, which is a very aggressive tumor arising from pancreatic ducts, and it features disorganized glandular structures with cellular infiltration. This cancer is often metastatic at presentation, and the average survival is around 1 year after diagnosis. Tumors are more common in the pancreatic head, and they lead to obstructive jaundice. It's associated with the CA19-9 tumor marker, and also with CEA, though that is less specific, and the most common genomic abnormality is a KRAS activating mutation. Now listen carefully, because the risk factors include tobacco smoking, which is the strongest risk factor, chronic pancreatitis especially if present for more than 20 years, diabetes, and age over 50 years. This cancer often presents with abdominal pain that radiates to the back, weight loss due to malabsorption and anorexia, and migratory thrombophlebitis, which presents as redness and tenderness on palpation of extremities. This is called Trousseau syndrome. And finally, obstructive jaundice may present with a palpable, non-tender gallbladder, which is known as the Courvoisier sign. You have reached gastrointestinal pharmacology. Let's start with H2 blockers, which include cimetidine, famotidine, and nizatidine, and there's a helpful memory aid. Take H2 blockers before you dine, and think, table for 2, to remember H2. The mechanism is a reversible block of histamine H2 receptors, which decreases hydrogen ion secretion by parietal cells. These drugs are clinically used for peptic ulcer, gastritis, and mild esophageal reflux. But now listen carefully, because the adverse effects are important. Cimetidine is a potent inhibitor of cytochrome P450, causing multiple drug interactions, and it also has antiandrogenic effects, like prolactin release, gynecomastia, impotence, and reduced libido in males. It can cross the blood-brain barrier, causing confusion, dizziness, and headaches, and it can also cross the placenta. Cimetidine increases renal excretion of creatinine, while other H2 blockers are relatively free of these effects. Now let's move on to proton pump inhibitors, which include omeprazole, lansoprazole, esomeprazole, pantoprazole, and dexlansoprazole. The mechanism here involves irreversible inhibition of the H/KAT-pase in stomach parietal cells, and that's key to its function. These are used in peptic ulcer, gastritis, esophageal reflux, and Zollinger-Ellison syndrome, and they're also a component of therapy for H. pylori and used in stress ulcer prophylaxis. You should remember the adverse effects too. There's an increased risk of C. difficile infection, pneumonia, and acute interstitial nephritis, along with vitamin B12 malabsorption, and decreased serum magnesium and calcium absorption, which could lead to an increased fracture risk in older adults. Are you following me? Let's continue with antacids, which can affect the absorption, bioavailability, or urinary excretion of other drugs by altering gastric and urinary pH, or by delaying gastric emptying. All antacids can cause hypokalemia. Now let's look at individual types. Aluminum hydroxide causes constipation, hypophosphatemia, osteodystrophy, proximal muscle weakness, and seizures. You can remember this with aluminum amount of feces, and the mnemonic CHOPS. Calcium carbonate can cause hypercalcemia, known as milk alkali syndrome, and rebound acid increase. It can also chelate and reduce the effectiveness of other drugs, like tetracycline. On the other hand, magnesium hydroxide causes diarrhea, hyporeflexia, hypotension, and cardiac arrest, and an easy way to remember this is Mg superscript 2 equals must go to the bathroom. Now let's talk about bismuth and sucralfate, both of which bind to the ulcer base, providing physical protection and allowing bicarbonate secretion to re-establish the pH gradient in the mucus layer. Sucralfate requires an acidic environment, so it should not be given with PPIs or H2 blockers. Clinically, these agents promote ulcer healing and are useful for travelers' diarrhea, especially bismuth, which is also part of quadruple therapy for H. pylori. Now listen carefully, because our final drug in this section is misoprostol, a PGE1 analog. It increases production and secretion of the gastric mucus barrier, and reduces acid production. It's used to prevent NSAID-induced peptic ulcers, because NSAIDs block PGE1 production, and misoprostol is also used off-label for the induction of labor, as it ripens the cervix. And to wrap it up, let's remember the adverse effects of misoprostol, which include diarrhea, and it is contraindicated in patients of childbearing potential, because it is an abortifacient. Now let's talk about anti-constipation drugs, starting with bulk-forming laxatives like methylcellulose and psyllium. These are soluble fibers that draw water into the gut lumen, forming a viscous liquid that promotes peristalsis. While effective, they can cause bloating, which is something you should be aware of if prescribing or taking them regularly. Now listen carefully, because osmotic laxatives like lactulose, magnesium citrate, magnesium hydroxide, and polyethylene glycol provide an osmotic load to draw water into the gastrointestinal lumen. You should remember that lactulose also treats hepatic encephalopathy. Gut microbiota degrade lactulose into metabolites like lactic acid and acetic acid, which help excrete nitrogen as NH4 by trapping it in the colon. But don't forget, the side effects include diarrhea and dehydration, and these may be misused by patients with bulimia. Next, we come to stimulant laxatives, such as bisacodyl and senna. These work by stimulating enteric nerves, which leads to colonic contraction. While they're useful for quick relief, the major adverse effect is diarrhea, so patients should be advised accordingly. Are you following me? Let's now discuss emollient laxatives like docusate, which are surfactants that reduce stool surface tension, thereby promoting water entry into the stool. This softens the stool and eases its passage, but again, the common side effect is diarrhea, so this must be monitored in long-term use. Moving forward, we come to lubiprostone, which is a chloride channel activator that increases intestinal fluid secretion. While helpful for promoting bowel movements, you should keep in mind that it can cause diarrhea and nausea as its adverse effects, so always weigh the benefits against the risks in your patients. Now let's examine guanylate cyclase C agonists, like linaclotide and plecanatide, which activate intracellular cGMP signaling, leading to increased fluid and electrolyte secretion in the intestinal lumen. But be aware, the adverse effects include diarrhea, bloating, abdominal discomfort, and flatulence, making them potentially uncomfortable for some patients. Lastly, listen carefully as we cover serotonergic agonists, such as prucalopride. These stimulate 5-HT4 receptors, which enhance enteric nerve activity and increase both peristalsis and intestinal secretion. While effective, adverse effects include diarrhea, abdominal pain, nausea, and headache. And don't forget about NHE3 inhibitors like tenapanor, which inhibit the Na/H exchanger, thereby reducing sodium absorption and increasing water secretion in the lumen. The common adverse effects here include diarrhea, abdominal pain, and nausea.